Is somebody giving a countdown?
We are live.
Good evening, good evening, good evening. Good evening to this evening of SICS in special situations. And I welcome each one of you, our honored chairpersons, our honored speakers, and our honored viewers. Thank you very much for joining us on this evening for the AIOS Scientific Committee SICS in Special Situations case files. I'll just run you through our introduction of our wonderful chairpersons and speakers. First and foremost, I thank the AIOS Governing Council for all the time, the support and the help that they afford to each of these webinars, and they are the backbone on which we are also dependent. The scientific committee team works very hard and works throughout the day and at times throughout the night, and we are there for you all throughout the year. Thank you very much, Dr. Amit Porwal, Dr. Feroz, Dr. Jatinder Bhalla, Dr. Krishna Prasad Kudlu, Dr. Parikshit Gupte, Dr. Somshila Murthy, and Dr. Sonu Goyal. This evening, a very special mention to our two moderators, Dr. Jatinder Singh Bhalla and Dr. Parikshit Gupte, for having done all the hard work of this webinar. Welcome, sir. Welcome, our dear President, AIOS, Dr. Mahipal, sir. Welcome, Dr. Namrata Sharma, Secretary, AIOS. Thank you very much for being with us. Welcome, Dr. Devashish Bhattacharya, sir, founder and chairman of Disha Eye Hospitals, West Bengal, and past president, AIOS. Welcome, sir, Dr. Amulya Sahu, managing and director of Kamal Netralaya Private Limited, Maharashtra. Thank you for being with us here, sir. We welcome Dr. Barun Kumar Nayak, President-elect of AIOS, HOD of Ophthalmology, PD Hinduja Hospital, Mumbai. Our chairperson, Professor KPS Malik, sir, ex-HOD, Safdarjung Hospital, ex-DDGHS, Government of India, and past president of AIOS and past president of DOS. Sir, welcome. Welcome, Dr. MS Ravindra, sir, chairman and medical director, Kartik Netralaya, Bangalore. Welcome, Dr. Ranjit Singh Dhaliwal, sir, senior consultant, Dhaliwal's Eye Infirmary, Nabha. Welcome our own Dr. Arup Chakravarti, Senior Consultant at Chakravarti Eye Care Center, Trivandrum, Editor Proceedings of AIOS. Welcome Dr. BNR Subudhi, sir, Senior Consultant, Ruby Eye Hospital, Baharampur. And welcome Dr. Deepak Mishra, Associate Professor, RIO, Institute of Medical Sciences, BHU, Varanasi. And now I hand over to these two young men who are going to take us through this very, very wonderful webinar today. Thank you very much.
Thank you, Dr. Partha, sir. Thank you, Dr. Mahipal, Dr. Namrata, and all the distinguished chairpersons and speakers. It's really a matter of great satisfaction and honor to be holding this prestigious webinar on SICS case files, that is SICS in special situations. With presence of galaxy of such SICS stalwarts, we are going to witness and absorb many pearls of wisdom and scientific knowledge that will help all of us to improve our scientific knowledge, skill, and acumen. I'll invite Dr. Parikshit Gogate, my co-moderator, to say a few words before we start the proceedings.
Before Parikshit, can we have a word from President AIOS, Mahipal, sir, and then Dr. Namrata, please?
Yeah.
Thank you very much, Partha, Chairman Scientific Committee, and members of the Scientific Committee for organizing this webinar on different situations, special situations, and how to handle them with the manual small incision cataract surgery. I think small incision cataract surgeons have done India proud, because this is a surgery that actually originated in this subcontinent, primarily from India. And it is being adopted all over the world as a quick, easy technique with minimal expenses for people across all regions in the world. I think the world owes the origin of SICS to India and to the great surgeons who are present in this webinar, and they will be discussing about various difficult situations and how one deals with them with the small incision cataract surgery. I think both small incision, manual small incision cataract surgery as also phacoemulsification are there to stay, and they will be coexisting with each other and complementing each other, and various people will use them in various situations as per their own skill sets and as per as their confidence level in doing a particular technique. So I think it is imperative that all of us also know about phacoemulsification as also about small incision cataract surgery. And that is why this webinar is going to be very, very interesting. And at times there has been a thought process that manual small incision cataract surgery has been neglected, but I don't think that is the case. And AIOS is fully behind, and the scientific committee also wishes to propagate this particular technique because it is giving excellent results in various situations, and is going to, even today, I think, I don't know the numbers, but I think it's a large majority of the surgeries are being done with the manual small incision cataract surgery. So I think a great show as expected as always from Partha and his team. The team is a fantastic team, and above all, I think what is important is that it is a team, because together everyone achieves more, and they are very, very cohesive. And I think it is something that we need to learn from how together we can really achieve wonders. So look forward to this energetic team of scientific committee and Dr. Bhalla and Dr. Parikshat, who are the moderators here, and all the other members of the scientific committee and Partha for giving this particular session. And we look forward to a great session. Thank you.
Dr. Namrata.
Thank you, Partha, for organizing yet another scientific program, which is of so much relevance. Actually, if you see, we are true leaders in the field of SICS for all over the world, globally, because whether it is Africa or it is Egypt or it is Barcelona or it is sessions in APCRS or sessions in APO, I think SICS has been all over and have truly taught the entire world. Especially the Indian surgeons have truly taught the entire world how to do SICS and what is the way to go SICS. So, Partha, congratulations to you and your team. And I'm sure the entire scientific team is going to do a great job. I can already see the members here. And over to this, I think you should begin this without much waiting. SICS is special, so SICS in special situations.
Thank you very much, Namrata. Over to you, Bhalla and Parikshit, please.
Yeah. Now I'll invite our dynamic scientific committee member, Dr. Krishna Prasad Kudlu, to introduce the opening batsman, the first speaker of the day, Dr. Satanshu Mathur, who's going to give his talk on SICS in black cataract. Dr. Kudlu, please.
Thank you, Balaji, and it's my honor to invite. I think I'm going to share the screen. Can you able to? Can you able to see the screen?
Not yet.
Yeah, no. Just a minute. Yeah, I'm sharing the screen. 1 minute. Share screen. Yeah, just a minute. Yes. Yeah. Are you able to see now?
Yes.
Yeah, please.
My pleasure to invite my close friend, my brother, none other than Dr. Satanshu Mathur from Uttarakhand. He is also chairman of Devbhoomi Hospital. He has got a lot of posts in different fields in our ophthalmology. Mainly, he's a honorary secretary for SARC Community Ophthalmology. He's a chief national coordinator for ICMS. He's also honorary secretary for North Zone Ophthalmic Society and also Uttarakhand Society. He's also chairman scientific for ACOIN Association. Also, he's a joint secretary for FBS AIOS. Also, he's an executive member along with me in IRSI. Also, he's a state representative to AIOS. I think we all been keep hearing from Satanshu. He always helped me in various kind of activity. Once again, over to Satanshu. We are going to hear something out of him, especially from SICS. Over to Satanshu.
Thank you, Kishan Azad Pullu, for giving my introduction so nicely. First of all, can you see the screen?
Yes, we can, sir.
Okay.
Please.
So, first of all, I'd like to thanks AIOS-SC Committee, Dr. Partha Vishwas' new team for giving us the platform for SICS surgeons. I have been asked to speak on the topic SICS in heart cataract, but I will say why the heart cataract. SICS is the operation of choice in all types of cataract, and once you reaches the end of this webinar, you will yourself come to know why I am saying so. When Dr. Boramani will be speaking, how you can control astigmatism, preoperative astigmatism and peroperative astigmatism by the incision size. So incision is very important. For the beginner, you can give a small incision or you can give the linear incision, but it will cause astigmatism. But once you have mastered surgery, it is the best incision nowadays, the linear incision with two sides extending vertically away from the limbus. That will cause the minimum astigmatism and will give enough space for delivery of the nucleus. For rhexis purpose, we should give 6 mm minimum rhexis. In 90% cases, we can achieve it. If required, we can give side incision to relax the rhexis. Incision size is not very important in SICS, in heart cataract, as we have to protect the endothelium. For the beginners, I will recommend big incision, 6 mm or 6.5 mm. They can give like this incision. We should always try to protect the endothelium in heart cataract. That is the advantage of SICS over the phaco in these cases. While making incision, we have to make side. We are making side pockets. That is very important to make the incision enlarge from the interior side. After giving side port, inject the methylene below the air bubble. Now enter from the wide port through 2.8 mm incision and the capsular rhexis. We should avoid this can opening technique. We should always try. We can achieve 100% cases this CCC. If it is smaller, you can make 2 radial incision. Otherwise, it is not required in all cases. Advantage of SICS in heart cataract is that you are peaceful mind. It is safety for the endothelium, for the patient and for the doctor peace, both. After rhexis, enlarge the incision up to 6.5 mm. And then you have to inject the hydro procedure you have to do at the repeated site. And whenever you're doing it, press over the nucleus so that pressure does not increase inside. Now you press it and you see from one side, nucleus has come out. Once it has come out from one side, you have to inject viscoelastic from below the nucleus. And then rotate it with 2 dialer into the anterior chamber. So nucleus is out from the back into the anterior chamber. And 90% work job has been done. Now you can take out from this place by so many methods, whatever you like. You fish hook, irrigative axis, sandwich technique. This is the irrigative axis. When we enter, the irrigation is off. When we just come up to the nucleus, the level of the wound, we start the incision. This is the heart cataract. How easily we can remove it, you can see. Then simply Simcoe cannula is used. You can implant PMM lens or you can implant the foldable lens for your requirement. So you can see the endothelium, cornea shining. This is the beauty. Next day you have very good vision and you can go for peace of mind in the night. Then hydrate both the side. Cortea done, so that conjunctiva is now. This is another. This is a flavor technique. Sound is inside. By snare we can remove this this hard nucleus by only 4.5 millimeter incision. This is another technique where we have given the incision. I would like to show you the incision we have told. This is side. We are extending this incision upwards away from the limbus, and that will give you enough space without much astigmatism. So this is incision, 5 millimeter incision for hard cataract, but 1 millimeter extended vertically.
We did the study in storage media. And so that doesn't necessarily mean
thank you very much.
Can you mute, Sunilji, can you mute everybody else except the speaker, please?
Done, sir. So,
His
Balla?
connection is lost.
yeah, so this lateral vertical extension of the wound that helps in causing minimal astigmatism and gives enough space. Why is it not coming?
It's
You
coming.
stop sharing.
We can hear you.
The screen is not shared, Dr. Satanshu.
Yeah, there's some problem. So this is the vertical extension of the wound. I will take 10 seconds because we have wasted time here. This is the special cannula I want to show you that you can. This is my friend Dharmendranath has made this cannula. He's given me complimentary cannula. I am working on this same cannula for last 1 year. You can remove this hardest nucleus by this cannula. Advantage of cannula is that there is a space in the cannula where the nucleus rests. You can see the hardest nucleus you can remove by this cannula. This is a black cataract, and you can implant the foldable lens. This cannula I want to show you. This is the cute cannula. You can see it has a bed. Over this the nucleus rests, and you can remove the nucleus easily. Thank you very much. Thank you very much.
That was a very nice exposition. Yeah, Dr. Satanshu, that was a brilliant exposition of SICS surgery in hard cataract. Now I'll request our discussants, Dr. Debashish Bhattacharya and Dr. Amulya Sahu, sir. Do you think, sir, in the current COVID pandemic where there was a lockdown for quite many months and a lot of our patients are coming with very hard cataracts, the surgery of choice can be SICS, particularly when we don't have any apprehension and fear of aerosol generation, sir? What are your comments on this, sir? Dr. Debashish Bhattacharya, sir.
Yeah, I mean, SICS is perfectly suited for hard cataracts because even in non-COVID times, basically the ultrasound damage to the endothelium is not there because if you are doing a very good incision and therefore, I mean, the incisional trauma in SICS is more and the ultrasound trauma is more in phacoemulsification. So we need to balance it out. But if the incision is well done, because that is the basic fundamental of doing hard cataracts, and we must see that the incision preserves the corneal valve and is big enough to accommodate the entire size, and there should be scleral pockets to accommodate the thickness of the nucleus, because more often than not, these nucleuses are thick. And once the incision is perfectly aligned to the size and the thickness of the nucleus, I think the rhexis has to be a big one, and that is not much of a challenge. And even if a rhexis is compromised in SICS, that is also not a problem, which again plays a role in hypermature hard cataracts where doing a rhexis becomes a problem. So given the situation, I mean, SICS is a good surgery and a good way to do hard cataracts of any kind, and we need to do it well. And I think everybody should know it. And especially in COVID times, yes, I don't know about aerosol generations, but I would say that it's good to it's a good surgery for the real black ones that Satanshu showed.
I think rightly said, sir. Just like a good batsman should know all the strokes should be there in his book. Similarly, a good ophthalmic cataract surgeon should be aware of all the techniques, be it SICS, be it FACO. He should be versant and conversant with all these techniques so that he knows which technique to use optimally in what kind of patients. Dr. Amulya Sahu, can we have your comments, sir? What should be the, what do you think is in hard, mature, dark, black cataract? What is the biggest size of rexes which you can make without compromising the integrity of the capsular bag, sir? And what are your comments regarding use of which viscoelastic should be used, whether it is plain methyl cellulose or GV to protect the corneal endothelium, sir? Your comments, sir. Dr. Amulya Sahu, sir.
There, the screen.
Yes, sir.
Yeah. So,
I think Dr.
Allah, you can ask any chairpersons. Dr.
Just one question from my side, Dr. Ballard, Dr. Kudlu here. One question towards
yes, sir. Yes, sir.
Dr. Debashish also here. I still remember I happened to operate in his hospital during the last time SSS conference, a 3 mm black cataract with the help of a instrument from Zeiss called MyLoop. Then I could be able to even implant a trifocal lens. I did a live surgery in the Debashish Sir's hospital. So my question to all the chairperson, I think with the invent of this kind of, already Dr. Satanshu had shown the snare to cut the nucleus within the antechamber. With the invent of such equipment, especially MyLoop or anything, I think whether the usage of the premium lens like trifocal or multifocal has been increased, I need to take an opinion from Debashish sir.
See, I mean, one thing the surgeon needs to decide that whether a particular cataract would do more endothelial trauma by ultrasound energy depending upon the hardness of the cataract. And as Dr. Bhalla rightly pointed out, and then he can decide as to the incision. And of course, the incision size can be minimized with the MyLoops and the snares that we use also from Anil Shah's videos. I mean, we've learned from him. So they can a very hard nucleus can very easily be bisected into or trisected into smaller parts. But whatever it is, because the loop has to cross the equator and go behind the lens. So, I mean, in any case, the incision size cannot be brought down to less than 4.5. So that is the incisional limitation. That much scleral dissection, corneal dissection, and trauma will occur. Now, if the hardness of the cataract is very hard, well, one can choose to go for SICS, and that's a very good option. And also use premium lenses. I mean, it's a way of doing surgery. The lenses are a choice of what the refractive outcomes we want.
Yeah, Dr. Bhalla, I have got a comment. So many times one minute, just one comment only. Many times these hard cataracts are associated with pseudo exfoliation and non-dilated pupils. Many times it's not so easy. Always whatever is shown is a dilated pupil, but many times the pupil is very small. So it's really challenging in these cases.
Yeah, Dr. Subudhi.
Rightly said, sir. We'll be
we have a talk on this small people SICS also.
But PEX, I'm telling you, pseudo exfoliation.
Yeah, pseudo exfoliation is granular weakness, and
if you permit, I will now ask my co-moderator.
Parikshit, you're not able to hear.
Yes,
No.
I think there's some. We will take his comments later on, sir. Now I'll request Dr. Parikshit Gogate to please invite Dr. Sonu Goyal for the next speaker, sir. Dr. Parikshit, please, sir.
Dr. Parikshit, you
Parikshit
unmute.
Parikshit is not audible. Is unmuted.
Parikshit,
Okay.
unmute yourself.
Dr. Sonu Goyal, I'll invite Dr. Sonu Goyal, our energetic scientific committee member, to please invite the next speaker, Dr. Lobsang Setem from Arunachal. Dr. Sonu, please.
So it's my pleasure now to invite the next speaker. He'll be talking on MICS in hazy cornea, Dr. Lobsang Setem. He's a gold medalist by the Equine in 2013, awarded the Global Eye Health Heroes 2016, Commendation Certificate awarded by the Government of Arunachal Pradesh, BMJ South Asia Award 2017, and has been awarded the IOH of India Award in 2019 by the AIOS. So welcome, Dr. Lobsang Setem. I hope I am pronouncing you correctly, sir. All to you.
Yes, sir. Yes, sir. Just a minute.
Dr. Lobsang. So please, yeah.
Okay. Is it visible now?
Yes.
Okay. Good evening, everyone. At the very outset, I would like to thank AIOS for giving me an opportunity to be a part of this wonderful webinar. So I'll be speaking on SICS in hazy cornea. So as you know, as an anterior segment surgeon, we have to be very proficient in both SICS and phaco, and it's up to our decision whereas to what procedure we have to tackle. But with cataract with corneal opacity presents a unique challenge. Hence, pre-op planning is very, very important for having a successful outcome. So success relies heavily on finding sources of potential complications during the surgery and also adjusting our approach accordingly. As corneal opacity hinders the view through the cornea, and hence it can pose challenging situations during the surgery. And also because of the scarred cornea, biometry concerns may be an issue. So hence you have to take a average K reading or the K reading of the other eye. So if you ask me what to go about, in cases of cataract with corneal opacity, SICS would be a better choice because it has lesser complications in terms of endothelial damage, PC rupture, and also IOL drop or nucleus drop. So you have either a simple scar, which may be central, paracentral, or limbal cell stem cell deficiencies, or ocular surface diseases, or diseases like endothelial cell dysfunction, like Fuchs dystrophy. So preoperatively, we have to consider the grade of the opacity, whether it is a nebular, macular, or a leukomatous opacity, location, whether it is located centrally or paracentrally, and also added pathologies as if there is, say, synechia or some other, say, corneal pathology, like as I mentioned, Fuchs endothelial dystrophy, because we have to then go for added surgeries. And also visualization through the cornea is also an important. So you have to enhance the visualization. And also you have to know your own surgical skills, whereas to whether you are competent with SICS or with phaco. And also we may have to go with surface optimization in cases of ocular surface diseases. And also proper lens selection is also very, very key in such cases. So for surface optimization, you either use say preservative tear substitutes, cyclosporine drops, or tear serums, or and also steroids before the surgery, which ensures a smooth surface, and it helps in accurate biometry outcome and topography readings. And it also improves the visualization during the surgery. Overall, the refractive outcome is better if you control the surface, ocular surface diseases. And also we may have to go with epithelial debridement before or during the surgery, or even we may plan excimer PRK 3 months before obtaining the final IOL calculations. In cases of healed viral scars, you have to go for antiviral prophylaxis 1 week before the surgeries. And also you have to give steroid drops under the antiviral covers, or nowadays you can also use NSAID drops. And in some cases, you may have to go for SLED procedures so as to optimize the surgery and then plan for cataract surgery. So for enhancing visualization, you have to use capsular staining devices like Trypan Blue, or you have to go for light adjustments. For that, you have to have a very good microscope. You may go with low to medium settings to reduce back scatter, and endo illuminators are very, very helpful, wherein you get better illumination, wherein you can do rexis properly. Dispersive OVDs are also helpful, because if you spread it over the cornea nicely, then also it enhances the visibility. And also in some cases, you may have to go for pupil expanding devices. So this is one endo illuminator wherein you can see that the visibility of the rexis is well pronounced, and then wherein you can do a better rexis. So I think I'll go with just a minute. So is the video visible now?
No, sir, it's not.
No, Dr. Lobsang, we can't see it. Can you
Yeah. So this is a case of a macular corneal opacity with cataract. We then use judiciously. Okay.
That's
can
okay.
you open the video separately?
Yeah, if you can open it separately. Okay, till Dr. Lobsang opens the video, I would request Professor KPS Malik. Professor Malik, sir, is one of the doyens of Indian ophthalmology. He is also the author of the first book of manual SICS, and he has done a lot of cataract surgeries with corneal opacities. Malik, sir.
Is Dr. Malik logged in?
I don't think Dr. Malik sir has joined.
He's not logged in.
I have not seen him.
We can take comments of Dr. Ravindra, sir, Dr. Ravindra and Dr. Dhaliwal, sir.
Dr. Dhaliwal, sir.
Good evening, everybody. My concern in a hazy cornea, like Lobsang said, initially biometry concerns. We got to use these lubricant drops frequently while we are doing the biometry. And capsulotomy is also an issue. Usually we do it by just putting some viscoelastic onto the cornea itself as we are proceeding with that. And my suggestion would be the least interference intraocularly. So once we are through with the capsulotomy, we used to prefer, and still I prefer, a nucleus tumbling technique. And just one instrument goes in, tumbles the nucleus, and injects visco under the nucleus and on the sides, bring it out, and then visco expression only. No other instrument goes in because of the hazy cornea. And capsulotomy is the main concern. And once we are through with that, I think everything should go fine. And premium lenses are a big no-no for these cases. And I would prefer a hard connect, these PMMA lenses for these cases.
Thank you, sir. Dr. Sahu, you were not for the last case. Would you want to say something about hard cataract and hazy cornea?
Video on now?
Can you share it again, Dr. Lobsang?
I think it's not.
Okay, so perhaps.
Sunil, is Lobsang there?
No, Dr. Lobsang is here, but it seems he's not able to.
I think there is a connection problem with Dr. Lobsang.
I think we can ask Dr. Amit wants to make some comment. Dr. Amit, you are muted.
I had a question to Dr. Lobsang actually. He recommended using of NSAIDs in case of corneal degeneration or corneal scar or anything. But as much as I know, we should avoid corneal NSAIDs, especially in patients having corneal disease, because the chances of melt is quite high, and it has been reported. So we have to be cautious when you are using NSAIDs in corneal pathologies when you are doing a cataract surgery. Second thing is we have all our esteemed panelists here. How many of you really use dispersive viscoelastic when you're doing SICs in corneal pathologies? I mean, I don't know. At least I am very, very comfortable. We got very good results with HPMC itself. So, is there a role of dispersive viscoelastic in SICs in corneal pathology?
HPMC is dispersive.
I mean, viscot.
If
the endothelial cell count is poor, it does have a role.
Cases, yeah.
May I comment on this? If
yeah, Dr.
You might be asking Malik sir's comment, so you can do it for him.
Okay. Sir is there? No.
No, ma'am.
I think Sir is not logged until now.
Okay. Anyway, so I think let's divide the whole thing into two aspects. One is the epithelial problems and other is the endothelial. So when we are talking of epithelial, what Dr. Amit was pointing out was the NSAIDs, basically when they cause corneal melting, it's primarily on the epithelial side that it acts. When we talk of endothelial disorders, then maybe, viscot would have a role if it's the endothelium is, we are going to tumble out the nucleus and put it into the anterior chamber. So one is that you are so experienced and that you know really how to handle things, and your chamber is adequately deep that after putting your, shifting your nucleus into the anterior chamber and coating it with the methyl cellulose, you are able to handle it. If not, then viscot does have a role. I would, put it that way.
Yeah, I agree with you, Ruchi, here, because we need to coat the endothelium with something, either chondroitin sulfate and hyaluronic acid based thing, or the soft shell technique of Dr. Steve Arshinov. I think we'll have more of these comments. Now, can we invite Dr. Amit Porwal? I would request my dear friend and co-member of scientific committee, Dr. Amit Porwal, to please invite next speaker, Dr. Chirag Mittal, for his talk. Dr. Amit.
Yeah, thank you, Dr. Balla. So it's a pleasure to invite Dr. Chirag. Dr. Chirag Mittal is basically a cornea, cataract, and a refractive surgeon practicing in Delhi from the last 6 years. He is an alumni of LV Prasad Eye Institute and is actively involved in research and teaching activities for postgraduate students and ophthalmology practitioners. So over to you, Chirag, for your presentation, please.
Thank you, Dr. Porwal, for the nice introduction, and thank you for involving me in this wonderful webinar with all the seniors. And I would be, I'm sharing my screen now. Okay, is it visible?
Yes, Dr. Chirag.
Yeah, so I'll be speaking on manual SICs in cases of combined cases of cataract and corneal transplantations. So as we know, keratoplasty, cataract extraction, and IOL implantation, these are known as triple procedures. And and for the long time, open sky ECC has been the preferred choice in full thickness penetrating keratoplasty. But since now lamellar procedures are gaining more values, and a lot of cases can be dealt with lamellar procedure, either endothelial keratoplasty or DLK. These are closed door procedures, and manual SICs is definitely a savior in these kind of cases. Also, manual SICs in case of cataract surgery post cornea transplant is my preferred choice, as it is a very controlled surgery and prevents endothelial damage. So the main challenges in these combined cases is visibility. They are very poor intraop visibilities in cases of endothelial decompensation, which decreases the chances of safe and predictable surgical outcome. We also are worried about a stable IOL implantation, because a successful cataract surgery affects the ultimate surgical outcome and graft survival. Also, in these cases, IOL power calculation is a challenge. In a clear graft, we can normally do a central K as we do in a normal cornea, but in decompensated grafts or corneas, other eye Ks can be taken, or if we don't have, in case of one-eyed patients, we can take standard K of 44 Ks. So the aim is to do a 1 to 1.5 diopter or so myopia due to an induced hyperopic shift by the optically active stroma when we do a DSEC or endothelial keratoplasty. So the ideal cataract surgery in these kind of combined cases is any surgery which is predictable and safe in hazy corneas. So we need a large incision to reduce endothelial cell loss during an endothelial lenticule insertion, and it should be a controlled environment. We need a complete cortical cleanup and a stable IOL. Also at the end, we need a water-out closure and also controlled astigmatism. So manual SICS has deep AC during all the steps, and it can be done to a 5 mm scale incision, which helps doing a push-in technique using a sheath glide for lenticule insertion. It leads to a watertight closure with low astigmatism at the end of the surgery. So I'm sharing this one case of an elderly male having recurrent pain with a diminution of vision since last 5 years and history of multiple episodes of topical steroids and antivirals. So this was a endothelial decompensation following a recurrent endothelial viral endothelitis. The patient didn't have any recurrences for the past 1 year, presented with stromal edema, a hypertrophic epithelium, and a dense cataract. So I plan to do a manual SICS cataract extraction with DSEC in this case. So as you can see, this case was referred for a full thickness penetrating keratoplasty because of this sort of view. This is but when we remove the epithelium, it's just the hypertrophic epithelium and comes off beautifully during the surgery. Due to the dense and long-lasting edema, still there is a very low visibility. So a can opener technique was done. I preferred a blue methyl incision with back cuts. So that was done, which gives adequate seal post-operatively, which is very important for the concluding steps of DSEC. The AC was entered slightly more into the cornea. Again, the idea was to give a very strong seal, watertight seal. The hydro procedures was done, and the nucleus was cartwheeled out in the AC before taking out by blue menthol technique. So this ensures that the AC is deep all the time. I use a bimanual with a reverse. It's like irrigation, more of irrigation into the back and aspiration into the AC, because it's almost a blind procedure, and we don't want to catch hold of the anterior lens fibers in our probe. Lens was implanted and dialed behind the AC before doing further DSEC procedures. So I generally do a Desmond stripping with reverse Sinsky hook and push in the endolenticule with the help of a 26 gauge needle. And this is known as a push-in technique. And this helps me make the orientation of the DSEC lenticule very clearly. A single suture was applied, so for astigmatism, and the case was concluded. So this was the first post-op day picture. You can see this, the edema is still settling down. And this is after 6 months, and post 2 years, the patient achieved 6/12 vision. Another case, this was a case of fungal keratitis non-resolving on medications. And we did a large therapeutic keratoplasty, and the crystalline lens was preserved. But as we know that the large grafts in these cases don't survive, and we had a graft failure with well-controlled IOP. So we waited around 6 months of the procedure for the wound stabilization. The most important thing in doing SICS in a post-transplant eye is to not cross the graft-host junction. But since this was a very large graft with no limbus visible, we had to do a SICS incision crossing the graft-host junction. So in this case also, we removed the epithelium, stripped the DM because there were a lot of pigments, so have a clear view. The graft-host junction was breached with this scleral tunnel, and since it was 6 months, the tunnel did hold up very well. Again, the nucleus was cartwheeled out and expressed through the blue menthol technique. The rest of the steps of the surgery were similar to the previous one. So we could implant a IOL and then do a DSEC successfully in this case. And it's because of a large width of the tunnel, which was self-sealing, and but we had to apply a suture just to make it more secure and prevent astigmatism. So this case also did fairly well. The post-op visual acuity was 6/18, and the patient is still holding well. So these are the cases which can be easily managed by SICS, And there are some complications essentially due to poor visibility, but which can be easily managed, like PCRs, ACL and glued can be planned in the same setting. Hyphemas from the iris central, which is not there in phacoemulsification, but air tamponade at the end can help preventing these complications. So this is my preferred technique for triple procedure. It gives it a watertight wounds. Generally, I use cohesive viscoelastics in case of DSEC because we need to remove whole of the viscoelastic at the end of the surgery. Keratometry, as I mentioned, can be taken from the other eye, and the aim is for 1.5 diopter myopia. Thank you. Thank you very much.
I think that was it was an excellent presentation, Dr. Chirag. I really compliment you for that. Now I would invite our panelist, Dr. M.S. Ravindra, sir. Please, we'll like to have some tips from you for doing this combined surgery of keratoplasty along with SICS, sir.
I think he did a marvelous job. Couple of tips that I can give is, if you are doing a penetrating graft, even in that case, you can do a bulk dissection of the anterior lamellae up to the Descemet's membrane or pre-Descemet's layer and complete the cataract surgery, then come back and do another cut. This I've done, in especially central leukomatous opacity where you can't see the lens and you don't want to do an open sky surgery, remove bulk of it and do the cataract surgery first. And as far as the water tightness is concerned, SICS is the preferred technique, not only in grafting cases, but also in vitrectomies. So after the surgery, the surgeon goes in and does a vitrectomy. They need a perfect watertight wounds, which is obtainable in SICS. In my colleagues, when they do a phaco surgery, the wounds will be leaking because of the high pressure inside the eye. So this is another condition where you can consider the SICS as a primary procedure. Third is we did a lot of studies on endothelium analysis post cataract surgery. Their endothelium can be preserved if you do a proper surgery to maximally with SICS. These are the 3 points that I can give. About the illumination, it's nice to take the endoprobe inside the anterior chamber, but short of it, you can always direct the endothelial, the endolight probe at the limbus, and you switch off your microscope light. You'll see much better. Depth perception is going to be very better, especially when you're aspirating cortex, when they're doing rexis, where you don't need the coaxial illumination. You can switch out the microscope light and use endolight. And in absence of endolight, even if you hold a torch there, a torch which gives a pointed light, like a muzzle torch, somebody, an assistant will hold a torch from a distance, and the light falling on the limbus or around the peripheral cornea, you'll have much better depth perception. These are my points, and very well presented. Both the talks were excellent.
Dr. Subudhi, sir, would you like to comment on the case of Dr. Chirag, sir?
Yes, excellent surgery. Many times we see post keratoplasty cases when you do the cataract surgery. So there are two challenges. The endothelium sometimes decompensates. Those, we were doing at that time penetrating keratoplasty. So in those cases, now we've seen that if we do the cataract surgery, we land in a lot of complications, and sometimes there will be a lot of endothelial decompensation and leading to again corneal heads. So of course now there's a DSEC and DALK has changed the whole scenario. So today's surgery is definitely quite good, and MS has the best technique in these cases. Thank you.
Agreed, sir. I think very valid point, sir. The illumination is really very important, and as Dr. Ravindra sir pointed out, holding either a fiber optic light at the peripheral cornea or limbus can really help us by switching off the microscope light. Now I'll invite my co-moderator, Dr. Parikshit Gogate, to introduce our keynote address speaker, Dr. Will Dean. Dr. Parikshit, sir, please.
Yeah, thank you, Dr. Bhalla, sir. I would like to introduce our international speaker, a keynote speaker, Dr. Will Dean. I have been knowing, can you see his picture, sir? Can you see the introduction?
No, please. You have to share screen, Parikshit.
Yeah. Now? Yeah. Can you see it now?
Yeah, we can see it now.
Yeah. Dr. Dean is an ophthalmologist from Cheltenhamshire, UK. I hope I'm pronouncing it correct, Dr. Will. But he's a dean in the sense, not just as a second name of dean, but he holds two hats. One is he is the chair of the committee which looks into international ophthalmology for the Royal College of Ophthalmologists of UK. And he's also the lead cataract for the subspecialty exams that the International Council of Ophthalmology holds. So other than just being an ophthalmologist from UK, he has a tremendous international exposure, and he has his special interest in glaucoma, cataract, and emergency care. He's also done his PhD in simulated ophthalmic surgical education in sub-Saharan Africa, where he conducted a randomized controlled trial for training manual small incision cataract surgery using intense simulation training. So over to you, Dr. Will. I think let's hear from him.
Fantastic. Thank you so much, Dr. Parikshit, for that very kind introduction. And thank you so much for the very kind invitation to join this expert panel for this very exciting and important webinar. I hope, can you see my screen there?
Yes, sir, we can, sir.
Yes, we can, sir.
Fantastic. It's been it's a privilege joining you at this meeting, and it's been a privilege seeing these amazing surgeries on very, very difficult cases. And I wanted to give a very brief international relevance of SICS outline, and then some recent innovations of training ophthalmologists for SICS cataract surgery. I will. We know from India, and I've spent many years working in sub-Saharan Africa, performing thousands of SICS surgeries in Malawi and Mozambique and Southern Africa, that it's very important technique, especially when we have very high volume situations, and it's also a very affordable technique as well. These are two density equalized cartograms showing where the blindness is in the world and where the ophthalmologists are. And we know from recent data that there are actually 42 million people who are blind in the world. That's just about to be published. And at least a third of those are blind from cataract, with over 50 million people having moderate or severe visual impairment from cataract globally. So SICS is a very, very important technique to tackle cataract blindness specifically. Worldwide, there are 230,000 ophthalmologists around on an average of 32 per million. In India, there are just over 11,000 ophthalmologists, about 10 per million, and it works a lot in sub-Saharan Africa. There are 2.5 ophthalmologists in sub-Saharan Africa. Annually, there are around nearly 15 million cataract surgeries performed per year. A very high proportion of those happily are SICS, especially in high volume cataract settings. It's important, as we're discussing today, to consider the presenting case mix and visual acuity. It's important in many settings to consider the cost of surgery. We know from comparative RCTs and many studies that the outcomes of SICS and phaco are very comparative. But we also know that environmental sustainability is important to look at as well for waste. But if you would permit me, I just want to share a few thoughts on training for cataract surgery, which is sort of the opposite end of the spectrum of much of the meeting today. We've seen some excellent surgery performed by truly expert surgeons on very difficult cases, and I'm sure we'll continue to do so throughout this very important webinar. But I'd like to spend just 5 minutes focusing on teaching novice cataract surgeons SICS and cataract surgery. And I've just completed a PhD looking at this, performing an educational and intervention randomized controlled trial for SICS cataract surgery training in sub-Saharan Africa. We know the problem is that there's a huge need to train more eye surgeons, more cataract surgeons around the world safely, efficiently, and effectively. But it's very stressful, especially when, as trainers, we know that there are long lines of patients waiting for surgery. How do we give our trainees opportunities? The traditional apprentice model of teaching, the see one, do one, teach one, takes a very long time and is very stressful for the patient. Many who are terrified of just being in hospital. It's very stressful for the trainee, but it's also very stressful for us, the trainers. Patient safety is paramount, and we know that trainees' complication rates are much higher in the initial learning curve, but there is a need to train many more patients. So I looked at the role of simulation-based surgical education for SICS cataract surgery, as well as trabeculectomy. Simulation is not a replacement for live surgical education. It's not a surrogate for motivation or just a one-size-fits-all. And it's not merely the presence of a wet lab or a microscope. There are many different types of wet labs that might exist, but simulation is not just the presence of a wet lab or a different model whether it's computerized or plastic eyes. A critical review of simulation-based education showed that for it to be impactful for our trainees, there needs to be feedback on their performance, sustained deliberate practice, there needs to be a curriculum and curriculum integration, there needs to be outcome measurement, as in measuring the outcome of their surgical competency. Skills acquisition and maintenance are important to enable, and then the predictive validity of transfer to practice, as well as opportunities for team training, instructor training, and there needs to be educational and professional context, as well as, importantly, reflective learning for trainees and encouraging motivation. There's lots of potential for simulation in ophthalmic education, and practicing complications, perhaps anterior vitrectomy in the case of SICS, is important. Returning to practice, especially for surgeons or trainee surgeons who might have been away, and especially now in the time of a global pandemic, for maintenance of skills and for assessment as well. Simulation offers an environment in which learners can train until they reach specified levels of competency. And this is what I just want to share with you just before we publish the results of the RCT. There's lots of evidence that, there's some evidence that simulation in ophthalmic education works, but there's never been a randomized controlled trial. We do know that for phaco training, that there is a slight reduction in complication rates. So we focused on cataract, and we know that certainly in sub-Saharan Africa, the median number of cataract surgeries performed by residents by their second year of training was 0, and in mainland China, the median number of cataract surgeries performed by residents when they graduate is 0. We frame simulation by talking about taking a novice SICS surgeon or cataract surgeon or ophthalmic surgeon to advanced beginner and competent. To become proficient or expert, that can only occur in a live surgical setting. So what we did was we deconstructed the SICS surgical technique. We provided instruction in each and every step and feedback, enabled sustained deliberate practice and reflective learning, and then measured the outcome with high fidelity artificial eyes and encouraging motivation along the way. So the SICS technique we deconstructed, we provide instruction for different steps, scleral tunnel, AC entry, linear capsulotomy or CCC, nucleus extraction using either a fishhook or other method, provided feedback, sustained deliberate practice, getting it right every time, and we allowed reflective learning by recording the performance of the SICS on an iPad, and then trainees mark themselves back using the simulation Oscar for SICS, which we developed and published recently. And this essentially breaks down the procedure of SICS into its constituent steps, and then allows you to mark the procedure for a novice, advanced beginner, and competent. And out of a total score of 40, you can mark a trainee on an artificial eye even before they start live surgical training. And the question as a trainer is fairly binary. If you look at the trainee on the left performing an SICS procedure, they've observed it before in theatre, in operating theatre, and they've seen videos, but they haven't performed. So it's a novice surgeon on the left. And after 1 week, 4 days of intense simulation-based surgical education, that's exactly the same trainee. And you can see the enormous difference in the performance. And it's a very binary question. Which trainee would you rather take to theatre for live surgical training next Monday? And the answer is fairly clear. So what we did was we performed the Olympics trial for SICS cataract surgery, and we assessed and enrolled 50 residents, registrars in 5 different countries in sub-Saharan Africa, randomized them to the intervention group who came for a 1-week intense simulation training course in Cape Town, and then the control group, and everyone carried on for 1 year. And we asked them to perform baseline surgical assessments and then assessments at 3 months and at 12 months. After the 12-month assessment, the control group came down to Cape Town for the same intense simulation training course for SICS. So these were the baseline recordings, and these are the results that I wanted to share with you. So what we have here is the objectively assessed surgical competence of SICS, and on the left here, you can see in the blue is a score of 10.8 out of 40, about 25%, 26% for the baseline, very similar for the control groups. And after the simulation training intervention, their scores more than triple. And the control group, their scores increase a little bit. And then after their intervention, the scores catch up enormously. Their confidence, self-reported confidence in SICS surgery, more than doubled and tripled. They performed 2.5 times more SICS surgery in the 1 year of follow-up, and the complication rates in that 1 year follow-up reduced by 72% in the intervention group who'd had the intense simulation training course. It was a huge team effort, and we are hoping to roll out the model and work with stakeholders around the world to further develop this model of training, which can help with the initial technique skills learning. We would hope to use it for practicing rarer complications for SICS surgery, and it would hopefully be very useful for returning residents to work after a period of a global pandemic. And I want to thank you very much for the invitation and for your kind attention this evening. Thank you so much, sir.
Thank you, Dr. Dean. That was a fantastic presentation. You added a whole new perspective to the meeting. We have in fact chosen these 7-8 special situation in SICS because in the All India Ophthalmology Society, we have hundreds, literally thousands of very experienced small incision cataract surgeons. But as you said, the outcomes are pretty similar in phaco and SICS. So we had chosen 8 situations where we believed SICS in fact has an edge over phaco, even where people are doing phaco emulsification regularly. And that is why these situations were chosen. But then you have added a completely different perspective, the international perspective, the training perspective, and well, how things will move ahead. Any questions for Dr. Dean? Because he's come back from hospital. So we used to think only Indian surgeons work all 7 days a week, but I think that's the case in UK too nowadays.
Dr. Sir, can you make some comments on wonderful talk by Dr. Wildeen? I think their Olympic trial has really opened up the vista. And it shows that just with intensive training of 3 months, their skill level, confidence level definitely increases by 3 times. That's a wonderful thing, sir.
In our AIOS conferences, we've had simulator-based training. In the last 5 years. But then RCT is an RCT. I mean, it's the gold standard.
May I quickly congratulate Will for being a part of this webinar. Thank you so much, Will, for being here and rushing from your hospital to the webinar. It was a very, very interesting talk that you gave. And you as a trainer, do you find that teaching SICS, and you have taught so many SICS, is comparable to teaching phaco for a novice surgeon? What would be your thoughts on that?
I think teaching SICS is different to teaching phaco. I think teaching phaco is so much more instrument dependent. And also, in my experience, has potentially a higher complication rate because it's an enclosed system with higher pressure. So yes, I think it's very different. I prefer teaching SICS.
So any RCT trials you have done on teaching phaco vis-a-vis to SICS?
We did trabeculectomy and SICS.
Okay. So what were the results of the study?
So the glaucoma competence more than trebled, and that stayed for an entire year. And they went on to perform 20 times more trabeculectomies in the 1 year after the simulation training.
Okay.
Wow.
That's really good.
That's great. So thank you, Dr. Dean. So
thank you so much.
Can you go on to the next speaker?
I think now can we go on to the next speaker, please, if there are no more questions. Yeah. Now I invite again our close friend and dynamic scientific committee member, Dr. Amit Porwal, to please invite the next speaker, Dr. Shrikant Sahu, to deliver his talk. Dr. Amit, please.
Excellent talk, Dr. Dean, and thanks, Dr. Balla, for inviting me, Dr. Shrikant Sahu. Dr. Shrikant Sahu is basically a cataract and anti-segment fellowship done from LVPI. He has got advanced training in corneal research from Stephens Eye Research Institute, Harvard, USA. He has over 50 peer-reviewed articles in national and international journals. So over to you, Dr. Shrikant. Would like to hear about SICS from you. Thank you.
Thank you all. Thank you all for inviting me. Give me a minute for sharing my screen. Is it visual?
Ready.
Yeah.
Dr. Will, if you are around, we would really like to take your comments on the different scenarios that we are discussing today, if it's all right with you. Will.
Yeah.
Carry on, Shrikant, please.
Yeah. Is my slide visible? Am I audible?
Yeah, Shrikant.
Okay. Hi. Again, welcome all. Thanks for inviting me. I would like to talk after a fantastic talk by Will. I'll talk about something little different in the sense. These people who have a coloratus eye are always, to begin with, are in a disadvantaged stage of visually. So, and when they come with cataract, it's still more challenging. The challenge is, one, there is scleral weakness at the cleft region. Two, there is zonal deficiency. We need to assess how much is the zonal deficiency. Most often than not, there is a pupillary dilation. The pupillary dilation is poor, and is most of the time also associated with many other things like microcornea, which we need to take care. Okay, so what is the priority, like the base? Is it phaco or SICS? Based on it's basically based on the grade of cataract, which will come down. The most important thing is we need to discuss with the visual prognosis with the patients beforehand. Reason is, even if you do a fantastic surgery, the outcome may not be good as per the patient because they already have an inherent deficiency. So we need to discuss that before the surgery. Yes, and also discuss that this surgery is not going to be the way a normal cataract surgery will ever be. What are the technical challenges? One is a steep and deep inferior scleral stapholoma. So the periorbital injection is little risky. So general anesthesia is sometimes best, but mostly not. Good periorbital anesthesia is great, but I would never ever go in for a topical, because most of us now do it topically only. But right now, in these kind of cases, there's a peripheral anesthesia which is good. We need to be ready with iris dilating measurements, how to dilate the iris if it's not dilating properly. We need to assess how large is the capsular zonal dialysis, and be ready with devices like capsule tensoring. Need to use more of dispersive OVDs. Also, a preoperative mannitol and a limited partial retrieve is sometimes advised to reduce the posterior pressure and prevent aqueous misdirection, which is very common in these kind of case situations. The other things which we need to take care is, one, there's a crowded or shallow antechamber, which is seen mostly in microcornea and if the small axial length. So in these kind of cases, we need to put OVDs, if at all, more often than not. The all-power calculation, some say because of the anticipatory effective lens position, we may induce some amount of myopia, hyperopia, but for me, I would still go in for a 0 target. Pupilloplasty is one important component which is more than other assessment methods, because here not only the lens, we have to help with the deal with the pupil. Now let's go to one of the cases which I will say. Now one thing for sure, the size of the incision would be little larger if what would have do for a normal case. Reason, we do not know how deep is the antechamber, so I do not want to really make the endothelium little compromise. So first, larger incision. Blue is a must because the rexis size is a little smaller than the pupil size, and to make the pupil size little larger, we can do sphincterotomies or by many methods. What I use is a microforceps, which people use for retina scissors to make the cuts so that we can have a, and blue stepping with blue helps with making the visibility for the capsule a little better. And in this case, what I'm trying to do is rexis, which I'm trying to do, which is larger than what the size of the pupil is, and the staining with different blue helps me to do it comfortably without even seeing the edges. And I need to do a large rexis because the capsule is brownish, which is mostly in case of coloboma. Now we do a large incision, and now this is the most important part. Here, do not ever put any pressure on the dialysis area. Now look at the dialysis, large one, the general dialysis and the lenticular dialysis. So here, without putting pressure, any pressure on the dialysis area, take out the nucleus, and you can see how the nucleus is hard. To a different thing is that I use a AC maintainer. I'll tell about it later, and take out all cortex, leaving apart from the area of the coloboma, so that you don't put any pressure. First, take out everything as far as possible. Loosen the whichever nut doesn't come out, loosen, and here do not put it perpendicular, put it tangentially, so that it does not put pressure on the journals directly. And some people even say leave the cortex a little bit to try to put the lens in the bag with the haptic in the journal dialysis area, so that it stabilizes the bag. Now, one thing for sure, which is a better method to take it out, which is a better method to do, what I would suggest is stick to the principles what you are comfortable with. Now, I am comfortable with blue menthol technique. What I did is I lowered the bottle height and did the surgery. The other option for me would be that to change it to a vectis delivery, because I'm not comfortable with the anatomy, the way of putting the vectis, and it will be much more dangerous. So what I would suggest, whatever you are comfortable with, be with the same technique, but ensure that the antechamber is deep. So, in a nutshell, what all things we need to learn from these cases? One, we need to do a little larger incision than what we normally do, so that there is no amount of stress on the antechamber or the endothelium, and the nucleus is delivered nicely. We try to ensure a CCG. Yes, one thing for sure, we can use a forceps, alternative forceps, or a pediatric rexis forceps, which is better for a rexis than a cystotome, but choice depends on you. But staining for the nucleus is must. If it's a non-dilated people, you need to do a sphincterotomy for or else at least use a AIOS-SC. For me, sphincter is better. A gentle hydrodissection without any pressure on the jonules which are weak is a must. Nucleus delivery by a vectis or a gentle visco or a blue menthol, whichever you are comfortable. If you are using blue menthol technique, a low visco, low bottle height is mandatory. For IA, leave the arc of coloboma to the last. Bottle height must be kept low to prevent fluid misdirection syndrome. And the crust is the area where coloboma is there is to be done last. And some people say leave it alone so that that area become opaque and the person is better off. Endocarpsula should be a ring, should be a hand if you think that the journalist is much more than necessary. You need to put the IOL in the bag with the haptics in the area of the journalist instability. If it is unstable, make it efficient. SFL is also another option. If the iris is a defect, as in most of the cases, some people do, most of them are not. We leave it as such because the eye adjusts itself in that axis, visual axis. But to make it round, we can suture it, and optical additive can be made to make the iris much more coherent with the corneal or visual axis. Thank you.
Thank you, Dr. Shrikant. That was very wonderfully done. Nice surgery, nice steps, and very practical take-home messages you have given. Just one point I would like to make: if there you find there is associated coloboma also, would you like to do barrage laser on the edges of the coloboma choroid before or after the surgery?
That is done before the surgery.
Before the surgery.
Before the surgery, yes. These practical things are done before the surgeries.
Right. Can I invite Dr. Arup Chakravarti to please give comments on this case of SICS in colobomatous eye, sir? Dr. Arup, sir, please. Dr. Arup, are you there?
Yeah, just before Arup, Dr. Kamin, I think I would like to ask the panelist a couple of questions. Dr. Amulya Sahu, sir, is also there. Suppose patients with the microcornea with the coloboma of iris. So after doing a good SICS, of course, there will be black cataract. The removal of the nucleus itself is very difficult. So when you are implanting the intraocular lens, especially if you want to implant a foldable lens, do you want to cut the haptics, or do you want to reduce the size of the IOL? Amulya, sir.
Yeah. Can you hear me?
Yeah, I can hear.
Yeah.
We can hear you, sir.
So I did 2 days before I did a coloboma case. So I had a vitreous prolapse also.
Sir, can you speak a little louder, Amulya, sir? Can you speak a little louder, sir?
Can you hear me?
Yeah.
Yes, sir. You are audible, sir.
Audible, sir.
Yeah, two days before I did a coloboma case, and that was a one-eyed patient. I had a vitreous prolapse in that case, and I put the lens in the sulcus. Some cortical matter could not have been removed at that stage, so we had to do posteriorly, and we had to remove the cortex by the second procedure. Now see that the lady I saw yesterday, she has a vision about 6/12 vision. So these are the difficult situations where there is no need to cut the haptics. If you are positioning it properly, I don't think you have to cut the haptics.
Yeah, actually what I did almost around 3 weeks before, sir, the microcornea, the overall the corneal diameter was so small and the nucleus was very hard. The nucleus delivery was uneventful. But when I measured, even the regular IOL size of 5.5 mm haptic itself is bigger than the cornea. Then I thought, okay, I will cut the 2 haptic. Then I have inserted this IOL within the bag, because bag also rexis. I did a big rexis almost stretching towards the zonule, sir. This is what doubt I had, so I need to discuss with all the panelists.
If I may be permitted.
If you are cutting the haptics, there is post-operative irritations you can face. Continuously, they will go on complaining.
I think
they're having some kind of pain and this kind of things.
That might lead to, yeah, Dr. Ruchi.
Yeah. No, I think we cannot generalize, I think, the whole scenario. It will depend on what kind of coloboma the patient has. Now, the coloboma, it's again going to vary whether it's involving the anterior segment, it's going to involve the posterior segment. it may be associated with a microphthalmic eye, it may be associated with an eye with a normal axial length. So there are different scenarios depending on what stage basically the development has been affected. Now scenario one, where the axial length is normal and we just have a situation where either the anterior segment is smaller in size. So again, the IOL power is going to vary. One has to be careful. If your anterior segment is a little smaller in size, then the routine lenses are not going to work. You have to either get a custom made lenses, what I think was being discussed. So if you cannot get a custom made lens made, then in that case I have also cut the haptic and I have put it into the bag and it works. It does work. And I have checked it up in the literature. People other than us have also tried it and it has worked for them also. But then there is a situation where the interior segment may not be all that small in size. There even a routine IOL will go and if you fold it, it will open up and go right and fit very snugly. So I think the whole scenario is going to vary from a patient to patient.
Thank you.
One quick comment, if I can make, please. Shrikant, excellent video you showed. One thing that I would think that would be pertinent is in such colobomatous lenses as which are associated with iris coloboma also and a deficient zonule in the inferior part. Placement of a CTR, a small CTR, to fit into the capsular bag before the delivery of the nucleus. I mean, we do this for phacoemulsification, putting in the CTR as soon as it is possible with a very gentle hydrodissection, and then going on to the maneuvers. Because in the SICS, as we know, that the maneuvers are macro maneuvers and would definitely compromise the zonules at some time or the other. So a CTR placement, small CTR placement. And the second thing that I thought is that what Kudlu also said, that these are associated with microcornea as well as microphthalmus. So the 12 millimeter PMMA lens, an overall diameter of 12 millimeter PMMA lens inside the bag might be a difficult proposition and might endanger the capsular integrity also. So here a single piece lens where the haptics actually fold on and crowd onto the optic and actually encompass the whole of the capsule could be a better option. And of course, the option of cutting the haptics, which actually might not be required because the crowding, the haptics can tend to fold on and be akin to the optic of the lens. So these are two things that I just thought would share.
Thank you, sir. Thank you for those valuable comments. Now, I would ask my senior in the scientific committee, Dr. Kudlu, to please introduce our new star from Pondicherry, Dr. Vivekanandan.
Thank you, Parikshit. I think, can you see my slide? Yeah.
Yes, sir. Yes, sir. We can see.
It's my pleasure to invite Dr. Vivekanandan, who is the head of Arvind Eye Hospital, Pondicherry. Of course, his area of interest is secondary IOL procedure. He has done a lot of training and he has his main interest building of hospitals, especially surgical training, even in Ethiopia, Cambodia, and Tanzania. It's very much privileged to even introduce him. He has done a lot of wet lab instruction, especially in AO and ACRS. I think we are eager to hear you, Vivekanand. So he'll be presenting some interesting case about the SICS. Word to you, Vivekanandan.
Thank you very much for the wonderful introduction, sir. Let me just share my screen. So today I will be talking about first of all, I would like to thank the AIOS committee for giving me this opportunity. And I'll be talking about the primary single haptic iris fixation technique in the management of large PCR, the SICS way. So in the age of phacoemulsification, when we are going to have a small pupil combined with pseudoexfoliation, hard cataract, and phacodonosis, it is going to be very difficult to perform phaco. It is going to cause more problems to the patient than solve any. So in these scenarios, Msics will be the best option for any type of surgeon. So SICS is a very important tool that everyone should know. So as we know, iris fixation was introduced by Dr. McCannell, and since there is a lot of other secondary IOL procedures like SF-IOL and iris claw, it has taken a back seat. But now the single haptic iris fixation is there to minimize problems and will be as a primary procedure when we have problems. So I'll be showing a couple of case scenarios. So the first case scenario. So this is a pseudo-exfoliation patient with gross phacodonosis, as we can see. So where there is a relatively hard nucleus, NS3 to 4 nucleus, which was delivered. And while cortex was, we could see that the inferior bag was totally weak. Since it was a very large rectus, there was no support inferiorly. So in this case, ideally what will happen is the patient will go in for us, will be planned for us SF-IOL later on. But here what we do is as a primary procedure, we are going to proceed with a single haptic fixation. So here we use a 10-0 proline suture with a long curved needle. The needle size will be approximately around 1.5 centimeters, so that it passes through the limbus and comes out through the limbus after piercing the iris twice. So this image describes, so after the bite is taken, the suture is externalized. So how do we externalize? By gently tapping on the iris, the suture is pushed down, and with the help of a Kugler-Suk or a Sinskey, it is gently pulled out into the outside the eye. Once that step is done, the leading haptic in this case, which had to go inferiorly, is looped a couple of times onto the haptic, and then, so as we see, multiple loops. I prefer to do 4 to 5 loops so that even if one loop slips, the IOL is going to be stable. So once the looping is done, the IOL is gently placed in the sulcus area, and the trailing haptic is placed over the capsule. So the main point to take here is it is always better not to dial these lenses. You have to use a forceps to place the IOL inside. If the pupil is small, like in this case, it is always advisable to use iris hooks sub-incisionally, not on the site where you have the sutures, but in this case, sub-incisional, you can have iris hooks to make sure that your haptic goes in the sulcus area and not behind the PC. So, and the other important point to note here is, it is always when you are placing the suture behind the iris, and you have to pull the sutures to tighten it, so you should always be careful when you're pulling the suture away from the optic haptic junction. So when you're pulling the suture away from the optic haptic junction, chances of the loops to slip away is there. So always make sure you pull the right side suture, the one that is closer to the optic haptic junction first, so that it tightens around the haptic, and then you pull on the other side to center the IOL. So once that part is done, the sutures are trimmed externally and then are internalized. So internalized meaning, so the sutures pointing out from the cornea are trimmed probably to 3 to 4 centimeter in length, and then they are internalized using a spatula. So once both the sutures are inside, it is always important to make a paracentesis right in between the two bites, so that both the sutures are externalized through the common paracentesis. Once the externalization is done, then it's pretty much simple. All you have to do is tie the suture, trim the knots, and then push the knot back into the anterior chamber through the same paracentesis. So the way of finding out if the suture has passed underneath the haptic, it is still intact, is when you pull the suture, you will see the iris lifting up. So when the iris is lifting, you can be sure that the haptic is, the sutures are around the haptic. In this case, I didn't have to do any vitrectomy because there was no vitreous loss, only inferior loss of bag was there. So this can be done as a primary procedure. And one other case scenario that I would like to share is, so this is a hard round cataract where phacoemulsification was attempted. normal 6 millimeter excess was done and chopping was done. So when I got the first chop right, and when I was going for the second chop, the hold was not so good. So we could see a zonular dialysis inferiorly. So I tried to salvage the bag with the capsule hooks, but when I was emulsifying the last quadrant, it ended up in a posterior capsular tear. So the primary corneal incision was posteriorly extended into the sclera and then converted into a sclerocorneal canal. And then anterior vitrectomy was performed. Ideally, it is better to do anterior vitrectomy before, after placing the bite. In this scenario, I had to do anterior vitrectomy. So after doing anterior vitrectomy and assessing the amount of capsule, in this case, superiorly there was, this is a temporal section, superior capsule was there, inferiorly there was no support, so inferior bite was taken. And in the same way, the sutures were externalized, looped around the haptic and then placed inside here. So this is a sutureless way of managing such complications. You don't have to leave the patient aphakic. And it can be done as a primary procedure. So if you have enough back support for one haptic, it is more than enough. It is a time-saving procedure. It can be done as a primary technique. And the post-operative inflammation is very minimal. You don't need any fancy equipment or fancy, specially designed intraocular lenses. All you need is a Kuglen hook and 10-0 proline suture with a long curved needle. It can be done as a primary procedure and also as a secondary procedure. If you have enough back support, secondary procedure when you're attempting to place the IOL, if there is enough support, you don't have to go for an SF-IOL, which is more tedious. You can opt for a simple single haptic iris fixation procedure. It has its advantages over scleral fixation and iris claw as a primary procedure. The main take-home messages that I would like to say is proper assessment before planning where to take the bite with Kuglen hook. So Kuglen hook is a very important instrument that you need. And preferably the first suture bite has to be done before the anterior vitrectomy and not after the anterior vitrectomy, because once you've done the anterior vitrectomy, the eye is going to be very soft and you cannot take the bite properly. You cannot plan it according, it will not come according to how you want it. And perform a proper anterior vitrectomy if there is any vitreous. Ideal to use a 3-piece IOL. It can be a rigid IOL, or like in the second case, you can use a 3-piece acrylic lens as well, foldable lens as well. And the most important thing is not to dial the IOL. So once the leading haptic or whichever haptic is fixed, don't try to dial. When you're dialing, what happens is the loops kind of tend to slip out from the haptic, which might cause an IOL drop. So always you can use an iris hook, like I said before, to place the IOL properly in the sulcus, or you can use a forceps, pronate, and then release. And the sutures should not be tied very tightly over the iris. You don't want the sutures to crush the iris tissue. You know, the sutures, make sure that it forms a loop over the iris. It doesn't touch the cornea nor the iris. So in that way, post-operatively, there won't be any problem in having dilatation.
In half a minute.
Thank you.
Thank you, Dr. I would request Dr. Devashish Bhattacharya to give his comments on this wonderful presentation. Or Dr. Sahu, sir.
Sahu, sir, we are not able to hear you.
Sahu, sir, if you can speak a bit louder.
I think it's not audible.
It's not audible.
Yeah.
Sahu, sir.
Dr. Vivekanandan, I wanted to ask you, have you done any studies regarding decentration? Have you tested the amount of decentration which it generates?
Sir, usually there is the decentration is associated when we plan to do a double haptic and both the sutures are not in the right place. But in single haptic, it is very much easy. Before even tying the knot, you can pull the suture tighter, it make the IOL centered and place it. Very rarely you see a decentration when we're doing a single haptic fixation.
Have you calculated any amount of tilt in your studies? Have you done?
Yes, sir. We have done that. It kind of resembles the posterior capsule IOL that we generally use. We even have a video of, we've tried using the AIOS-SC microscope to assess how it comes. And they were perfectly normal. There wasn't much tilt. So before making the
Excellent.
permanent knot, it is very important to tighten.
Yeah.
That's why I'm saying, have the suture a little bit looser on the iris so that it doesn't tilt to one side. It stays in the PC.
Thank you, Vikrant.
Great, thank you. So, over to Dr. Bhalla.
Yeah. Now it's my privilege and we are fortunate to have Dr. Jagannath Boramani with us to deliver his next talk. I'll introduce Dr. Boramani. He's one of the pioneers of small incision cataract surgery. In fact, he's the executive chairman of International Society of MSICS. He's won 6 awards in MOSCON, first prize for paper in PG section, then Dr. Pandit Award, Best Academic Private Practitioner Award, and Dr. Chitnis Oration Award, and the Best Video Award. He was also given Santivision Award by AIOS-SC in 2014. He has done live surgical demonstrations in various places in India and also abroad, conducts wet labs and talks in ESCRS, WOC, APACRS in South Africa, contribution in 7 textbooks, ex-editor of Journal of ISMSAICAS, and his chairman of World Conference CCC 2015 and 2019, which we all know was a hugely successful conferences. And over to you, Dr. Boramani, for your talk on astigmatism management in SICS surgery, sir.
Yeah. Thank you, Dr. Bhalla. Can I share my slide?
Yes, sir.
Yes, sir.
Can you see my screen?
Yes, sir.
We can see it, sir.
And you can hear me?
Yes, sir.
We can, sir.
Okay. First of all, let me thank the office bearers of AIOS and the scientific committee for giving me this opportunity. I am going to speak on the management of astigmatism in SICS. Scleral tunnel incisions are very secure, they heal very well, and they are forgiving type of incisions. A little bit of raggedness here and there and little bit variation in the size also does not matter much because they are well away from the optical axis. If anyone is asked what is the advantage of phacoemulsification over SICS, it is always said that it is the less induced astigmatism because the incision in phaco is a very small one. Mostly it is about 2.2 millimeters clear corneal incision. But if someone asks me what is your induced astigmatism in your case, the question is very irrelevant to me because in my case the person should ask how much astigmatism you can neutralize because I got my methodology of customizing the incisions. So generally from 0 to 2.5 astigmatism I am neutralizing because you don't get all cases only with 0.25 astigmatism, that too only with the temporal steep axis, so that you can tackle with a 2.2 millimeters clear corneal incisions. Your presentations of the cases are varying, different types of astigmatisms are presented. All of you know about the incisional funnel. I don't want to go into the detail. The purpose of having a front incision is to have less astigmatism, but the center of the incision is nearer the limbus, so the maneuvering of the instruments in the chamber are quite easy. If you have a straight 6 millimeter incision, approximately it induces about 1.75 diopters of astigmatism. That is the purpose. The incision is now curved, which is called as a front incision, to induce the less astigmatism. So if you make it more and more curved, naturally it will induce less and less astigmatism. So this behavior can be used for neutralizing the pre-existing astigmatism. So after doing a lot of cases with different types of astigmatism, different shapes of astigmatism, and different sizes of the astigmatism in various quadrants, I have formulated my own nomograms. For example, if it is approximately about 1.7 astigmatism with a steep vertical axis, I will utilize a 7 millimeter straight incision. Bring down the size of the incision and progressively you will induce less and less astigmatism. With a 5 mm, it is about 0.82 diopter with a straight incision. Make the incision a little more curved, naturally the astigmatism will reduce. So make it progressively more and more curved, and if you have got a perfect U-shaped incision, generally it will not induce any astigmatism because very small curved part in the center will take part in the induction of the astigmatism. Temporally, the incisions are slightly weaker because they are away from the optical axis. Even a straight 7 mm incision will not induce much, it will induce only 1.08 astigmatism. Make the incision small to have a smaller astigmatism. If the temporal incisions are made more and more curved, they'll induce less and less, and they can be almost astigmatically neutral. Superior temporal and superior nasal, their behavior is in between the superior and temporal incisions. To have a perfect result, preferably center your incision exactly on the steep meridian. so that the vector forces from both the sides are acting very well. Whatever may be the size of the incision, straight or curved, it should be centered on a steep meridian, so you will have a better result. The question is where to sit for the surgery, because the steep axis can be anyone, but you can have almost 180 degrees in the right eye and another freehand 180 degrees in the left eye, so that you can always avoid the nose. And maybe for right eye, you can operate between 20 degrees and 200 degrees. Similarly, you can operate between say 340 degrees and 160 degrees in the left eye. So you can sit anywhere depending upon the steep axis and neutralize. So all your one type of incisions you can put in one table. These are the softwares available on the internet to calculate your surgically induced astigmatism. So after doing about 15 to 20 cases, one type of incision, one shape of incision, put it in one table and you'll find out how much mean induction of the astigmatism will be there. So before showing the surgeries, I'll just show you few topographies. The post-op topographies are almost 20 days after surgery. Here it is only 0.39 diopters of astigmatism, which has been further brought down with a curved superior-temporal incision. In this case, it is a 1.12 diopter of astigmatism. So I utilize a straight incision to neutralize it to 0.15 diopters. Similarly, this is a temporal 1.4 brought down to 0.09. This is temporal steep 1.24 diopter with a temporal straight brought down to 0.34. Now, this is a case of multifocal IOL. There is almost no astigmatism, so I have not induced any astigmatism. It is almost same in pre and post-op. Now, these are the two interesting cases. Patient non-affording patient presented with 3.49 diopters of astigmatism. Patient couldn't afford toric IOL. So with a big straight incision, I brought it down to 0.64. The induced astigmatism was 2.98. This is another case. This was a patient affording one, 3.3 diopters, but without using a toric IOL, it was brought down to 0.5. So you can market this surgery as a premium surgery, even without using a premium IOL. So instead of paying more to the company, you can charge more surgical charges in such patients. This is a case of a doctor patient who wanted multifocal IOLs, and his astigmatism was 1.97 diopters. The steep axis on auto was 165. Here also I didn't use a toric IOL, and I brought down his astigmatism to almost zero. It is 0.15 only. I utilize this is a left eye. I utilize a straight superior nasal incision, and patient is enjoying a perfect vision without any refractive error. So this way you can customize your incision. So I prefer calling the terminology surgically corrected astigmatism instead of surgically induced astigmatism, because the upper one sounds like a unwanted pregnancy, the lower one sounds like a planned child.
Thank you, sir.
To have a perfect result, you should mark always in the sitting position. Use all the toric IOL marker instruments. Mark the 0 and 180 degree meridian, and then mark the center of the incision when the patient is lying down, whatever may be the shape of the surgery incision, and around the mark, this mark should come at the center of the incision so that you can have a better results. The advantage of this technique is that suppose there are two cases having two diopters of astigmatism, you are using only one type of incision in both the cases, but there can be some variation. Instead of having a perfect zero, there is under correction, only 1.5 neutralization, and maybe in the second case there is 2.5 neutralization. So even if the error of the neutralization is almost 1 diopter, you can be mostly around zero, either on this side or that side. So either it can be 0.5 astigmatism in one meridian, or maybe it can be 0.5 in the meridian which is right angle to the eye. So this way we can customize the tunnel, and with this tunnel engineering, it is possible to wipe out or at least minimize the stigma of the astigmatism. Thank you very much.
Thank you, sir. Your presentation is always very, very lucid and always teaches something new. May I ask Dr. Arup Chakravarti, one of the finest cataract surgeons in the country, to give his comments on that? Dr. Arup, sir? Or if Dr. Arup is still taking his time, Dr. M.S. Ravindran, sir. I mean, sir, you also done fantastic work on astigmatism after cataract surgery.
What I would recommend everybody is to analyze your data right from every case and make notes as to what you've done to get what kind of results. I would like to, put in certain inputs that in SICS we tend to mimic the phacoemulsification by reducing the size of tunnel, but in phacoemulsification, the tunnel size has to be small so that there's no leak of fluid and you can keep the high pressures inside the eye. So that is not so in SICS. So SICS, our main aim is to preserve the structures of the eye, like preserve the endothelium, preserve the zonules, preserve the capsule, rather than trying to reduce the tunnel. Tunnel, as Dr. Boramani Jagannath has beautifully illustrated, we can manipulate the tunnel. Every hand, every surgery is different. There are hundreds of kinds of SICs. Whatever kind of SICs you are excelling in, always you can excel only when you match what kind of astigmatism you have produced in every surgery. So unless you have the data, as on Excel file, you can easily create it, and you can calculate SIA based upon it. And in your own hands, in your own setup, you have these data, and then you can apply, as Dr. Jagannath said, into your practice. So it's nice to mark the steep axis in every case, whatever it is, whether it's multifocal, unifocal lenses, mark the steep axis. I have compared the incisions on steep axis and non-steep axis, even when we are putting toric lenses. If you are done your incisions either on steep axis or on a flat axis, instead of an oblique axis, for example, if there is a withdrawal astigmatism, you go into a tunnel at 12 o'clock, or if you can't reach 12 o'clock, do it at 9 o'clock at a 3 o'clock position. Your astigmatism results is going to be different when compared to doing it in oblique, meridians. So there is a lot of factors that come into mind. Use standardization of surgery. External incision, internal incision has to be standardized using the correct blades, and then apply that onto the system and find out your SIA for a particular kind of surgery. As he beautifully said, different incisions you can make, different excels, or you can create, there are excels, there are a lot of varieties in doing it. You can take out the incisions that you have made, and then get the results and apply it in your practice. This is the biggest advantage we have in SICS. Thank you.
Thank you, sir. I think that is the take-home message which Dr. Boramani put forth and Dr. Ravindran said, is that we have to look at our own astigmatism, right, and we have to think differently for each and every patient, depending upon what were our results earlier. Thank you, sir. For the next speaker, we have one.
Parikshit, can I just ask one question from Dr. Boramani, sir? So, yes. Fully correct the astigmatism? Like, do you try to overcorrect against the rule and undercorrect with the rule? Number one. And number two, sir, depending on the profession of the patient, would you like to leave some amount of myopic ATR for near vision, or with the rule for distance vision?
Correct. If the patient is illiterate, correct. If the patient is illiterate, especially, he is more happy if you induce a slight amount of myopic astigmatism with the steep axis vertical. So you can do that thing also, but the methodology is same. So instead of perfectly neutralizing the astigmatism, try to make him say -0.5 diopter astigmatic with the steep axis vertical. Steep axis horizontal, or the meridian of the cylinder vertical. So this way the illiterate person will be happy. But when a person is going for a toric or a multifocal IL, then try to make it astigmatically totally neutral. I am putting multifocal ILs with more and more confidence because I know how much astigmatism I have got a very good control over the astigmatism. Secondly, after my presentation, you will feel that I don't put toric ILs. It is not the case. If the steep axis is horizontal, generally, it is very difficult to neutralize more than 125 or 1.5. So in such cases, I use the toric ILs.
Can I just add one point here?
Yes.
Okay. Number one is with the rule, astigmatism changes to against the rule with age. So younger the age, you minimize the correction that you're going to do on with the rule. You try to leave a half diopter there. This is one point. The second point is astigmatism is not bad as was put up. It adds to the depth of field, depth of focus. So you leave it 0.75 astigmatism against the rule. They'll have, you put a unifocal lens correct for distance, and he'll be able to read near. So astigmatism is not a villain all the time. Consider it as a friend, especially in a person who is using a lot of computers, a lot of things. You can leave a 0.75, 0.5 astigmatism against the rule. That's the one which gives maximum depth of field. These are the two hints that I would like to give. Astigmatism correction also, as I've noted, depends upon the corneal torosity. A steeper cornea and a smaller cornea will correct more of astigmatism per given incision when compared to a flatter and a larger cornea. These are things you'll have to keep in mind when you're calculating the SIA.
Thank you, sir. At the outset, then, I would like to invite Professor Ruchi Goyal. Well, Professor Ruchi Goyal needs no introduction. She is one of the pioneers in small incision cataract surgery. Can you see ma'am's profile?
We can see. We can.
Yeah.
See.
And she, Professor KPS Malik, has been the author of one of the first books on manual small incision cataract surgery and has been teaching this extensively over the past 2.5 decades. She has, of course, numerous academic awards to her credit and numerous book chapters and gold medals. I won't go into them because, ma'am, we would like to hear more from you. So over to you, Ruchi, ma'am.
Thanks, Parikshit. And thanks, Dr. Partha and Dr. Bhalla. And I think it's always nice to speak on SICS, a subject which is quite close to my heart. I started my residency writing this book, so it's really nice to be with it always. Now, I think the topic which has been given is SICS with trabeculectomy, and see, I'm not a propagator that one should learn just one technique. I would say that one should know phaco, SICS, all the techniques equally. But there would be situations where I would definitely go for a SICS trap vis-a-vis a phaco trap. And those would be a lens-induced glaucoma, a very hazy cornea with a very hard cataract where, doing phacoemulsification is going to be tough. And already if the pressure has been high for long period, your endothelium may be compromised and your corneal integrity may not be all that good. So these are the other usual indications that we have. Now I'll directly go on to a video presentation. This is a case which came to us. She had an extremely shallow anterior chamber. It's an old patient, 65 years, and the pressures were high to the range of nearly 40 millimeter of mercury, and without drugs. And as you can see, the pupil was fixed, dilated, and it was not constricting. So the diagnosis was either a lens-induced glaucoma or it was basically an ACG with coexisting cataract. We looked at the other eye, and the other eye also had a similar picture. Probably she had again presented in an attack and got herself operated. So I'll just go through the steps of SICS with trap, the procedure that we follow. So you can see the cornea is so hazy inferiorly, and the pupil, look at the irregular pupil. Nowadays, I prefer to use a limbus-based flap. And the important part is that we need to dissect very carefully, both anteriorly as well as posteriorly, a very minimal cauterization. And this is the flying eagle technique of the incision, which myself and Dr. Malik has published in DJO. And you can see this is how the center rectangular shaped flap with a frown on either side. This is about 2 millimeter from the limbus. A very careful dissection using a crescent blade, anteriorly about 2 millimeter again into the cornea. Most of these eyes are going to be extremely congested. You can see there, this is I also prefer to use a NTA chamber maintainer. Staining is particularly important, and as now you can see, the capsule is wrinkled over here, the cornea is hazy, the chamber is practically flat. So one has to be very careful. Rhexis was not possible with a cystotome. So I decided that after staining, I'll use a capsular rhexis forceps to create whatever capsular rhexis I can. Now again, it is extremely important that you should place the IOL in the bag, because once you're doing a trabeculectomy, if your IOL is not in the bag and you're not able to dilate post-operatively, you tend to get more synegy formation. So this is the hydra expression of the nucleus. And once I put on the red glow, now see how bad the cornea was. You can hardly see anything. So this is the PMMA lens which is being placed into the bag. And after putting pilocarpine, we could hardly constrict the pupil. I don't use a punch. I use a MBR blade. So you can, make two small entries, and you can use a vanas to cut a block. This gives a very neat kind of a sclerostomy. And this is a peripheral iridectomy being performed. And this is to check whether an adequate iridectomy has been made. Two sutures are placed on either side of the flap, and the meticulous closure of the conjunctiva is important. Also, it is important not to over dissect the conjunctiva, because we may need a second trabeculectomy at a later stage in any glaucoma patient, and even a glaucoma drainage device. So important message is that we should not dissect too much of conjunctiva whenever we are doing SICS. So you can see a nice bleb being formed superiorly. And the intact bridge of the corneal lip, it helps in decreasing the prevention of against the wound drift, as well as the post-operative hypotony. Now, to conclude, SICS alone may be done if the target IOP is achieved with medication. Alteration of incision site may be required if it's a pre-existing bleb. Minimal dissection of conjunctiva, which I'm iterating again and again, is very important in any trabeculectomy procedure. Now, a single site combined surgery lowers the IOP about 14 plus minus 3 millimeter of mercury over a year of follow-up in my hands. And if I need a even lower drop of IOP, I would then, sometimes combine it with MMC. Thank you so much. Any questions are...
Thank you, ma'am, for perfectly sticking to the time. I would request Dr. Dhaliwal, sir, to give his comments on ma'am's. Yes. Please unmute yourself, sir.
Yes. I'll not have many comments to make about Ruchi's presentation, because I'm from a place, small time practitioner. I have always been wary of combining the two surgeries. I found it paradoxical to operate for cataract as well as glaucoma, because in cataract I always wanted a perfectly sealed wound, and trabeculectomy, to my teachings, to my experience, was basically not a trabeculectomy, it was a filtration surgery. And so I would always be preferring one sealed surgery and a filtration surgery the second time, and in between I would rather try to control the pressure with glaucoma, or the glaucoma with drugs. But Ruchi, with her teaching experience and the research experience, I think she works wonderfully well. Thank you.
Can I answer, Parikshit? Can I answer?
Yes,
of course, ma'am. Yes, please.
Okay, sir. What you are saying is kind of perfectly correct. There are, again, one can really not generalize any situation. Now, there will be a situation where you have a 0.9 cupping and you're lowering the pressure is more important than, doing a cataract surgery. And that is only possible if you are able to see the fundus. That means your cataract is not all that advanced. So there, I would agree, I would only go for trabeculectomy, and I will not go for a cataract surgery in the first instance. Now, there is an instance where your cataract is so advanced that your, management of glaucoma is going to be hindered. One, because you cannot see the fundus details properly. So, and the second is that you cannot do any perimetry or any other investigation because of that. In those cases, I think it would be preferable to go for a combined surgery. Now, whether I would go for a single site or two site, again, if I want a more lowering of pressure, I would go for a two site surgery. If I want a lesser lowering of pressure, I would go for a single site surgery. Now, there is a third scenario where you, which I showed, that you have a lens induced glaucoma, or a very extremely shallow AC, a hard cataract, or a cataract which is too advanced. There, I would go for a combined surgery with a manual small incision cataract surgery. So again, sir, as I said, one can really not generalize anything in any patient. So the management would differ. Yes, please.
And ma'am, also we have a lot of patients who are from rural background, who are poor, or we are not sure their follow-up. So if we do a cataract and just put them on medication, they may not put the medication, or they may not come for a regular follow-up. So managing glaucoma in the same setting has many other effects also.
Absolutely correct.
So,
Absolutely correct.
I think very well done.
Dr.
Can we have some comments, Dr. Deepak? Dr. Deepak, you are muted. Deepak, I agree with Dr. Ruchi. Only thing is, I'm more in favor of doing two-side surgery rather than single-side surgery, for the simple reason being it causes less trauma and less chances of bleb failure subsequent period. Otherwise, I think it's very well done surgery in Dr. Ruchi's hands.
I would again go for a single site when it comes to SICS.
Yeah,
because doing a twin site in SICS is a lot of conjunctival dissection.
Yeah.
As a glaucoma surgeon, we would like to preserve as much as possible the conjunctiva virgin. So when
True,
it comes
Dr.
to SICS trap, I would always prefer a single site.
True, sir.
Just to answer Dr. Dhaliwal's, dilemma as to whether it should be a tight wound or a leaking wound, the thing that works best is do a releasable suture. Releasable suture closes the wound, and then you have just the phaco tight wound. And about 2 to 3 weeks later, you can titrate depending upon the response. You can remove the releasable suture. Then you have the best of both the worlds.
Thank you, Dr. Rendra.
Thank you, sir. So, Bhalla sir, can we have the next speaker?
I think, yeah, now, since Sonu is not there, I'll just, Now I'll invite next speaker, Dr. Jayashri Barua, to give her talk. Dr. Jayashri Barua is a young dynamic surgeon from Guwahati. She has done in fellowship in comprehensive ophthalmology from Shri Shankardev Netralaya, Guwahati, and then subsequently did fellowship in medical retina from Arvind Eye Hospital, Madurai. She is presently president of Assam chapter of AIOS-SC. Over to you, Dr. Jayashri, for your talk.
Thank you so much, Bhalla sir, for the nice introduction. And at the very outset, I would like to thank the scientific committee AIOS for giving me this opportunity to be a part of this wonderful webinar today. My slides are visible, right?
Yeah.
Okay.
Yeah.
Very good evening once again. And now I'll be speaking on MSICS in a small pupil. We are talking about the condition that is present in only 2% of the general population. But when it's present, it poses a challenging situation because it increases the risk of complications. Now, there is no fixed size to be termed as exactly to be termed as a small pupil, but pupil size is something which is relative that depends upon the surgeon's skills and the techniques that we are using, the ocular comorbidities, as well as the iris tissue properties. Now, there are lots of causes of small pupil, but what are the problems that we face when we get a patient with small pupil? Apart from the difficulty in the assessment of the grade of cataract, we don't know about the zonular complex integrity. There is increased risk of damaging the iris. And in SICS, what happens? We need a larger size of the rhexis, which might be difficult when we are having a small pupil, causing difficulty in our nucleus delivery, evacuation of the cortical matter, and problems in ensuring in the bag placement of IOL. Now, there is a stepwise approach for managing the small pupils, which I will be dealing in a series of videos. But the most important tip when we are dealing with a case of small pupil is to always stain the capsule with a dye, because even the minimum amount of capsule that is visible underneath the pupil can be of great help at times. And what we have to do is the rhexis should always be underneath the pupillary margin, and then we can cartwheel the nucleus out of the rigid small pupil. Now, in such cases, some surgeons prefer to use a flower petal type of rhexis, where what we do is we give 2 strokes within the pupillary area and 2 strokes outside the pupillary area, so that we get a more or less a flower petal pattern. Now, these are 3 different types of 3 different patients having the same size of the pupil and the same grade of cataract. In the first case, just with the intracameral injection of the dilating drops, the patient is, the pupil gets dilated perfectly. In the second case, we go for viscomydriasis. Yeah, viscomydriasis is working, but because of the leaky side port, what happens? The visco comes out, pupil again gets constricted. Third case is a case of an actual true pupil where no amount of intracameral injection, no amount of viscomydriasis is going to act, and we have to proceed in such cases. Sometimes in cases of small pupil, we might need to modify some of the techniques, like when we are prolapsing the nucleus, we have to be very careful. We have to be sure about the rhexis margin, about the integrity of the posterior capsule. In the first case, what I am doing, I am just trying to lift the nucleus out into the anterior chamber. And in the second case, what is happening here, instead of cartwheeling the nucleus, I'm manipulating the pupillary margin so that it will allow my nucleus to come up into the anterior chamber. Now, if the intracameral injections, if our viscomydriasis is not acting, we have to go for the iris manipulations. The most easiest of all is the stretch pupilloplasty. Since I don't have the Kruglan's hooks, I'm using two iris hooks, the two dialers for stretching the pupil. And this creates just minute sphincterotomies, which helps in minimal dilatation of the pupil. Wherever we get cases of posterior synechia, like in the second video and the third video, we have to do the sweeping synoculisis all along the 360 degree of the pupillary margin. In the third video, we have also to remove the membranes that are present in the cases of trauma. The fourth video, where we have an occlusio pupillary, where I also, as Dr. Shrikant has mentioned, I prefer to use the micro scissors because it gives me easy access even through my side port. So after doing the micro sphincterotomies and on injecting the viscoelastics, what happened? We get more or less adequate pupillary dilatation, almost similar to the BHEX dilatation that we achieve. Now, even if this also doesn't work, iris hooks are nowadays easily available and are very easy to use and also to remove. And why we need this is because sometimes we may end up in surprises like this. And while using the hooks, we have to remember that we don't have to stretch it too much, only the amount that is sufficient to allow us to have a good rhexis that's enough for the dilatation. Apart from the hooks, the rings are also readily available, and the beauty of the rings is that apart from the easy insertion and the easy removal, these are least traumatic to the iris tissue. So we have to keep even the iris rings into our consideration when we are working with small pupils. So first is a case of a BHEX ring, and the second is where I have used a Mallorin ring. Thus, by using this minimally invasive approaches, we can minimize the risk and optimize the outcomes. These are the pre and the post-op pictures of two of my patients, the videos of which I have already shown. So we have to know how to handle the small pupils. We have to be familiar with the various techniques that are available at our disposal. And if we know these techniques, then we can approach our cases more confidently. And whatever be the size and the shape of the pupil, we can give a perfect outcome to all our patients. Thank you so much.
I think that was a very nicely delivered talk and excellent videos and presentation.
Thank you so much.
If you have to do non-invasive way of dilating the pupil, would you like to introduce some agents like diluted epinephrine or phenylephrine, or now we have a drug introduced by some Indian company where they have combination
Yes, sir.
of
Actually,
tropicamide,
sir, I have used it in the first video that I have shown. There I have used only intracameral. It was acting perfectly. Just an intracameral injection and the pupil got dilated sufficiently. So the surgery was smooth. The first case was with intracameral injection, sir. The first video.
Although it is, I think, the skill of the surgeon, they can get away with any size of the pupil, but it is, we have to remember that trauma to the sphincter and iris will introduce more of inflammation, more release of prostaglandin, and more chances of cystoid macular edema, besides causing trauma to the iris tissue, which can later on cause pigment release and photophobia and glare to the patient. So it makes sense to do a traumatic surgery by dilating the pupil with what means that are available to us, either pharmacologically. And another comment I would like to make is that we always are concerned that IFIS is a disease which is mostly in the males, taking tamsulosin or alpha adrenergic antagonist in males. But we have to remember that these alpha and adrenergic antagonists are also being taken by females. So we should definitely take history of these kind of drugs like prazosin, etc., because it's a drug which is recommended for hypertension and urinary incontinence. So that part of the history is very important, which we sometimes forget, sir. Dr. Deepak, would you like to make some comment? I think Deepak has joined.
Yeah, Professor Deepak, sir.
Thank you, sir. First of all, Like, first of foremost, I would like to congratulate Dr. Jayashree for showing us tips for all the aspects of the. As far as our experience is concerned, in cases of SICS, we can have SICS slightly upper edge in where the small pupil is there, because there is less chance of iris trauma, and when there is the less chance of iris trauma, there is also the less chance of post-operative inflammation. Number one. Also, it helps. It is more easier to clean the cortical matter left inside in the small pupil, because cleaning of the cortical matter is again a very important aspect in the cataract surgery. And in case of SICS, small SICS cleaning of cortical matter we can done easily by the help in the SICS. And third one, as sir has told, in cases of FICS or another thing, you can also, for the small pupil, whenever there is surgical maneuver is required or the placement of rings are required, it is easy to place in when you are doing the SICS as compared to another thing. Thank you, sir. Thank you.
I would like to make a small comment. Jayashree, as usual, an excellent presentation. But one negative remark which I would like from my side, you mentioned about rings and BX, malignant ring and BX. So these are a very useful tool when you're doing phacoemulsification. But when we are doing an SICS, especially if the nucleus is hard, then when you try to prolapse the nucleus, even if it's a small nucleus, if you try to prolapse the nucleus, the ring or the BX gives way. It gets released. So I personally feel SICS, we can manage small pupil with the pupil manipulating things like the Sinsky, or as you showed, how we can prolapse the nucleus by playing with the iris tissue. Or the more invasive if you want, I feel the iris hooks. But the BHEX or the malignant ring doesn't give us so much of wonder effect when we compare to the other methods. That's all. Thank you.
Yeah, that's right, Dr. Amit. Actually, this is only up to the point of making the rexes. After that, actually, BHEX or whatever it is, it's not necessary.
Actually, one important
Yes,
thing
sir.
with
Yes,
the
sir.
iris retractor, iris hooks, is one important thing is that when we do capsular axis, we have a full view. We can do easily. And then I used to rotate the nucleus out of the bag. Then I used to take out one or two hooks wherever we need the space for the more.
Yes, sir. Yes.
So this is the advantage with the iris hooks.
Any of the other panelists would like to make a comment? Dr. Ravindra, sir?
Yeah, it's a very good compilation of videos. Dr. Jayashree, can you tell us, in a small pupil, you ended up with a small CCC to begin with, then you realize that the nucleus is larger than CCC. How do you manage such situations? Can you give some tips on it?
So in such case, I'll definitely go for the iris hooks even after, suppose I have made the first rexis. I like at least to know the extent of my rexis size. If it is too small and I need to go underneath the pupillary area, I would like to have a little bit of exposure of the capsular margin. So maybe I'll go for iris hooks at that step also, sir.
Now, what is your technique to enlarge the rexis? The rexis has become small, you already completed. Now you're not very comfortable in handling the nucleus through it.
Yeah. I prefer the micro scissors, giving a nick and doing a re-rexis over it.
Very good. Dr. Boramani, sir, you wanted to say something?
Yeah, I have a few comments. Like, say, pupil expanding devices have no major role in SICS because that is the advantage of SICS. At the most, you can use the hooks, but generally the need is very less because the nucleus itself acts as a pupil expander. When you're rotating and taking the nucleus out in the antechamber, the nucleus also expands the pupil. So that acts as a pupil dilating device. That is the one thing. Second thing, making a CCC in small pupil, even if your pupil is not very big or comfortable, if you're not able to visualize the margin of the CCC, still you can proceed by judgment only and you can complete the adequate size of rexis without visualizing the advancing age of the capsule rexis. That can be easily done. That's my comments.
Usually what I feel is when we are doing rexis in a small pupil, if we can get a bit of decentered rexis. I mean, I have a habit of prolapsing the nucleus. So whichever part of the nucleus, suppose the nasal or the right side or the left side of the nucleus, I have a habit of prolapsing. So that side, the rexis is enlarged a bit more. So even if the pupil is small, I know that because the rexis is a bit decentered that side, my nucleus will prolapse out from that pole. So can just retract the iris with the Sinsky hook and then dial it out. So this is also a very good technique of decentering the rexes in case of small pupil when you have large cataract.
The other thing that has come to my help many times is what Dr. Kiranjit, Dr. Daljit Singh's son, has introduced, oval rexes.
Yeah, oval rexes.
You are worried about doing a large rexes for the fear that it may run off. So you do, oval rexes or a triangular rexes at portions, regional levels. You go out and come back again, go out and come back again, and that will again give an excellent, control on the retaining the rexes as well as having a larger rexes for the nucleus to come out. So
that's what I meant, Dr. Mesa, that the decentered rexes is you can do an oval rexes at one particular part where you want to prolapse out the nucleus, and the other side you can have the normal circular fashion. So one quadrant of the rexes is oval in shape.
So one small thing, we had Dr. Lobsang Setting. He had joined us from Itanagar, and he couldn't show his small video because there was some net connectivity issues. So Dr. Lobsang, can you quickly show us the video just now?
In the meantime, if Chirag or Shrikant.
Thank you so much, sir.
Quickly.
So, is it visible now? So
Yes.
there is a case of cataract with adherent leukoma, wherein you have to go for the separation of the adherent leukoma. You have to use a spatula, and then also you may have to use scissors. So we strain the capsule and then do the rexes from the seeing area, and we use a capsular rexes forceps, which gives us good hole in the non-seeing area, and then we complete the rexes. So the rest of it, you may have to go for optical iridectomy, or also some special lenses also we may need to be used. So so this is a case of cataract with pterygium, a bilateral pterygium. So a big bilateral pterygium was there. So we removed that pterygium part with the scissors, and then we did pterygiorexis. Yeah. So then we removed the temporal pterygium also. Then we advanced the conjunctiva along with the limbal stem cells, and then we sutured with 80 sutures. So, and we also debrided the corneal epithelium for better visibility, and also removed the scar tissues. And then we proceed ahead with the cataract surgery to make to make the cornea more visible, we used copious viscoelastic substance over the cornea, and also used BSS to clear the blood which was lying over the cornea. And then I do a transconjunctival scleral incision. So here I am making a side port, and then I am doing a transconjunctival scleral incision, and rest of the procedure would be same. So yeah, so we are prolapsing the nucleus, and under hydroimplantation I am putting the lens. So after putting the lens, then we do the side port hydration and then closure of the surgery. So another scenario is with endothelial dysfunction, as one of my colleague has already mentioned. So I won't be touching much into it. So we may have to go for double combined surgeries with either with DSEC or DMEC, and combined approaches are most cost effective, and it hastens visual recovery and prevents the need for multiple surgeries. We may also have to go for sequential surgeries, wherein we may have to address the corneal part before going into cataract surgery. But if cataract is significant and if the endothelial count is good, then we may go for a cataract surgery alone. So we may have to use viscoadaptive OVDs, or we may have to do soft shell techniques, wherein we want good coverage of endothelium, and also we want adequate space. And for decompensated isolated folks, we have to definitely go for combined procedures. So to conclude, we can say that cataract surgery through cloudy cornea presents many challenges that requires careful preoperative planning and also intraoperative strategies to achieve a satisfactory visual outcome. But no single approach can guarantee full success. Hence, appropriate combinations are needed to minimize many avoidable and disappointing outcomes. So this is a story I'm sharing. This was a girl child who we picked up from a blind school. She was 7 years old. She had bilateral adherent glaucoma. So on the right eye, she had a bit of clear pupil and visual potential was there. So we operated on the right eye. We did cataract surgery and optical iridectomy. So now she has a vision of 6/18 and she is a happy going school going child. Thank you so much.
Great.
And
Thank
sorry,
you, Dr.
sorry,
Lotha.
and sorry for the poor network out here.
No. Thank you for closing it on such a lovely note.
The last remark was very good, Lobsang.
Dr. Bhalla sir for the last comments. Again, the AIOS has always been very supportive of manual small incision cataract surgery. Last year, we had a SICS experts meet to write the AIOS-SICS guidelines. So, well, we had a lovely evening. Thanks to all the presenters for sticking to the time and the discussants for their invaluable contribution and comments. So over to Bhalla sir and Partha sir for the last word.
Bhalla,
just stop your screen, sir.
Dr. Lobsang,
Lobsang, stop sharing your screen, please.
Okay, sure.
So I think before Bhalla or I put in the concluding remarks, any remarks from any of you? BNR sir, Deepak is there, Chirag is there, Sadanshu sir, Shrikant, Amulya sir, Boramani sir, Vivekanandan, Ravindra sir, any comments?
It's a wonderful webinar and all the speakers have done well. Excellent learning from all the speakers, from the panelists. Thank you all.
Dr. Partha, the concluding point of this website, this webinar is that so many speakers, so many chairpersons, good discussion, but we have finished in time. So credit goes to both the moderators for doing the great job. Thank you very much, yes. And thank you.
Can I come in?
Yes, sir. Yes, sir. Boramani sir, please.
No, I think after the first talk, the question was asked, how big incision can be left sutureless? In my opinion, a straight 8 mm incision, if properly constructed, can be left sutureless. If the incision is from, or if there are good radial extension, even you can go up to 9.5. If you are very much posterior, the ends of the incision, it can be left sutureless. But whatever may be the size of the incision, everyone should check the integrity of the wound at the end of the procedure, maybe by pushing liquid through the side port and see that the wound is not leaking. That is one thing. Secondly, there was a comment in the beginning that the aerosol generation is less or no aerosol is generated in SICS. That is also not correct. It is definitely less than phaco because you are not using ultrasound energy. But when you are doing the hydration of the side ports or when the assistant is putting water on the cornea, aerosol can be generated. So you have to change your technology. I am using AC maintainer in all my cases. So I was not using viscoelastics in the antechamber in most of the cases. But now I am using viscoelastics in all the cases, not in the chamber, but on the surface of the eye, because that will reduce the aerosol generation. Even during the hydrodissection, again, put a bolus of viscoelastic on the side port and do hydrodissection. And your assistant now should not put saline or the BSS with a cannula. The cannula should be removed and the syringe, the nozzle should be brought very near the eye. And just by drop, you can put the fluid. Even when you are aspirating in your syringe, initially we used to just push the aspirated fluid out. Now that pushing has to be done in the pouch. Maybe preferably keep some gauze pieces and do this thing. So this way you should take care of the aerosol generation in the COVID pandemic.
I think Vivekanandan has Arvind Pondicherry has a very good video which shows prevention of aerosol generation SICS. Yes. If I'm not mistaken, Vivekanandan, you can share it in our group so we can circulate it pan-India.
Sure, sir. Sure, sir. I'll share it with the group.
So one small question to all our panelists and our speakers as well. In vitrectomized eye, where the support of the vitreous is not there, what special measures would you take for such situations? SICS in a vitrectomized eye.
MSR, sir.
Answer this?
Yeah.
Yeah, we do a lot of vitrectomized cataract surgery. It's very easy, actually. You don't have to do anything. The fluidics, the pressure that goes inside the eye and the pressure that comes out of the eye, the suction that you has to be well balanced. And what extra you need is, see, the zonules are weak in these patients, so do not do a misdirected fluid gush in front of the anterior capsule and under the iris. This is a very common thing that we are all experiencing. We just say intraoperative hard eye, but actually what has happened is BSS has gone in front of the anterior capsule, behind the iris, and when you push a jet of fluid and that goes through the zonules and the pressure inside goes up. How much fluid can increase the pressure? A drop of fluid, less than half a drop of fluid can increase the pressure by 10 or 20 millimeters of mercury. You all know we inject Avastin or inject Lucentis into the eye. How much we inject? 0.05 ml. That much in a closed eye can increase the pressure by 10 to 20 millimeters of pressure. So we'll have to be very, very cautious when we're doing hydrodissection. Number one. This is very important in post-vitrectomized eye. You should ensure that nothing goes back. The silicone oil can come through the zonules into the anterior chamber and will keep on leaking. So the balance of fluidics in the anterior chamber. See that the AC is not very deepened. See that the AC is not very shallow, and both can be achieved by very good, by balancing of fluid that goes inside the eye and fluid that comes out of the eye. The next thing is the same thing I would like to tell about coloboma. Coloboma, there is an open, entry to the vitreous cavity. So I start rhexis not before the coloboma, but after the coloboma. You finish the entire rhexis in the zonules, and in colobomatous area, I either continue it, or if I see any fibers coming out, I stop there and cut it with the vanners. So this gives a perfect circle. Start it after the colobomatous area when you're starting it. Depending upon your routine habit of if you're starting at 6 o'clock, 3 o'clock, everybody has a pattern in that. So, but in colobomatous eye, you always start it after that so that the weak area of the zonules is handled at the end. So these are the 2 points or 3 points I would like to contribute.
Yeah, I'd like to add, in post-vitrectomy eyes, we sometimes like see a PC plaque, not opacity, but we see a PC plaque which needs to be taken care, and is very easily ripped off with a Sics also. Don't be afraid to take it out without taking a Sics on the posterior capsule, because it is easily separable with a Sics and with a rhexis fossa, if you have, it peels off. But that is one aspect which most of us, when we start, we are afraid. But once we do, we need to take out care of that PC plaque.
I think also less of fluid turbulence and more of visco usage, adequate visco usage is very important in post-vitrectomy eyes. It is basically what Dr. MSR was mentioning. It is the fluid disturbance or the jet of fluid which causes all this problem. So if you have a nice visco covering all around, adequate, not over tight, then your surgery becomes more near nice and tedious.
Some of the times the actual precipitates or opacity of the posterior capsule can be on the back of the posterior capsule. So there you cannot get it. It's on the back of it. The vitrectomy, while doing it, he has come quite anteriorly, might have touched the posterior capsule. Then the fibrosis occurs on the back of it. These you cannot remove it. You just leave them, put the lens there. And when they remove the silicone oil, probably they'll excise the central, plaque when you're doing it. So don't confuse. There can be dots of it. There can be plaques of it. There can be fibers on it, on the back of the posterior capsule, which you cannot remove. If you are overzealous, you will tear the posterior capsule.
Yeah, another short question about PC and SICS. Vivekanandan, Jayashree, Chirag, any comments? Shrikant, Deepak?
Your voice got broke in between, Partha. PC.
Yes, sir.
PPC.
PPC.
What was the question?
Post-polar cataract and SICS. Special precaution.
Sir, I prefer to give a little bit of pre-op oral glycerol or Diamox to the patient, just to, in case we have vitreous loss, to condense. That is one thing. And I 100% recommend all our residents to stain the capsule properly, because, in case it drops, at least we should be able to place the lens in sulcus. And my primary aim would be to debulk the nucleus. So I'll do a delineation, not very vigorously, gentle delineation, remove the nucleus. And I prefer to do a visco dissection of the cortex and epinuclear plate. So even if there is a dehiscence, it will not drop. It will come out in toto. So the visco dissection is something which I really prefer to do.
Yes, Chirag.
I prefer to do the blue method technique. So AC maintainer really helps in these times and prevents rapid shallowing of the AC in these cases. So even if case I have a PC dehiscence, the AC is not shallow at the rent doesn't extend much, and I don't have a uterus collapse. So that is one thing AC maintainer really helps in these cases.
Yeah, the question of AC maintainer and not using AC maintainer will always continue. We all Arvind fellows, we always believe that irrigating vectors is our weapon. And Alvivia people always believe that AC maintainer is the best. So whatever works best in the individual's hand, that should be managed. So the key is visco expression, small rexes. That is the key to it. And a good hydrodelineation. I'm sorry, Chirag, but you can go ahead.
Yeah.
Yeah, Chirag.
I
No,
think
that's about it. I just wanted to add that I am very comfortable with AC maintainer, and that's the my choice. It's just in what works best in everyone's just like that.
Any last comments from our panel speakers? Yes, sir.
I would like to expose my flank to Dr. Partha for any bashing that he might like to give me. In a case of small pupil, after I have made a good rexus and if need be radial cuts in the capsule even, we were always very comfortable with the nucleus tumbling technique. Just one stroke and the nucleus even through the smallest of pupils, and the nucleus itself dilates the pupil. Somebody had mentioned that a little while back. Thank you.
Sahu sir, your comment. Please unmute yourself. You have to unmute yourself, Sahu sir.
Dr. Sahu, sir?
Yeah. No, the audio is not audible
Audio
at
is
all.
not working.
Now we can hear.
Yes.
We can't hear.
Dr. Partha, oval rexis is always very helpful in posterior cataract cases and in small cases.
Yes.
We should always try to do it. Whether FECO we are doing SICS is always very helpful.
And we've been doing a rexus and paracentric. I have always moved it towards my tunnel. So that makes life very easy later on.
Sahu is not available. Dr. Sahu sir, they are asking for your comments.
अभी आया अभी आ रही है अरे अभी आ रही है
Come closer to the microphone.
You are not audible, sir.
Can you hear me?
Yes.
Yes, now we can hear you.
Partha, thank you very much. When you are contesting, I made it a commitment from you that SICS you are going to promote. And thank you for giving this opportunity. It's been a wonderful. And all the speakers were of high quality. And I enjoyed listening to them. And I think I spotted few talents whom I want to rope into our group. So next presentations, we must have a much better attendance. And this time, I really enjoyed. And thank you, Partha and AIOS for giving this platform. I think at the end, the AIOS realizing this SICS is our contribution to the world, and they should back it all the way. And I will be tying up with Will. I heard him, and Will has a big presence there. And I have heard the Sivananda, Vivekananda. He say I think is must be with us, and with his reach outside, ISMSS will have a lot to contribute. So all the speakers were outstanding. Thank you so much. At least I was audible, but I am audible now. Thank you so much.
Thank you. You are very audible, sir, always.
So this has been a good experience, and all the moderators were perfect. Mallaji,
Thank you, sir.
to see great ho. Very nice.
Thank you, sir. Thank you.
It's really wonderful.
Parikshit is representing us, so I know that.
I know that, sir.
Thank you.
Thank you.
Yes, Balla, your comments.
Thank you, sir. Why
Chairman Scientific, please help us design a training program in all India.
Absolutely, sir. Absolutely. Absolutely.
Yeah, now Parikshit and Boramani and all these people in the picture, and I will tie up with Vivekananda also should be there. And I have told some few thing Carla, Pamela will be there in the formulating this training program. Now the we have listened, so will be there also. We have an international training program immediately. So let's try hard. So this will be a SICS for all India, this India's presence abroad. Okay, our next program is 24, so we have about 10 foreigners that are there. So Partha, thank you.
Thank you, sir, for those wonderful comments. I really agree with you all. That in SICS, what is most satisfying for us of our ophthalmologists is that element of satisfaction is more, because you are giving the results 6x6 vision to the patient without aid of any machine or equipment. So your skill is more involved, and that is more gratifying. So now I would express sincere gratitude to all. Dr. Partha, our dynamic chairman, who has conceptualized the whole webinar and given us directions what to do. And also gratitude to our president, Professor Mahipal Sachdev, Secretary Dr. Namrata Sharma, for providing us the opportunity. And SICS luminaries and founders, Dr. Debashish, Dr. Amulya Sahu, Dr. TPS Malik, Dr. Boramani, Dr. Dhaliwal, Dr. Ravindra, Dr. Subhut, Dr. Arup, Dr. Ruchi, all the esteemed speakers, they have all shared their valuable knowledge and experience. And I really cannot thank enough my co-moderator, Dr. Parikshit Gogate, for all the help, and the colleagues in the scientific committee, Dr. Kudlu, Dr. Amit, Dr. Sonu, Dr. Somshila, Feroz for all the support. And last but not the least, thank enough our sponsors, CIPLA, for their timely support in all our academic endeavors. Dr. Partha, sir, for your final comments.
And Mr. Sunil.
Can I have a word?
Sunil, I forgot Sunil and the team, sir. But I cannot thank you enough. I've troubled you a lot of times.
Can I have a word?
Yes, sir. Yes.
Say, in the end, I want to say that this is a manual small incision. It will not be called manual small incision. You cannot call a 6 mm incision a small incision. So for my side, I am contributing the name. It is a manual scleral incision cataract surgery or magical scleral incision cataract surgery. Because as Ravindra also, I will tell him that the small incision, you cannot negate it. You do it 2 mm, and then you have a right to comment. If you are not doing it 2 mm, you cannot have the authority to comment that it is not possible. So when you say MSICS, it will be 2 mm or 3 mm MSICS. Otherwise, it will be manual scleral incision cataract surgery, or you can put it magical scleral incision cataract surgery. So not manual small incision with 6 mm. That will be my name. I am giving it to it, because we will be otherwise hypocrites. We cannot call a 6 mm a small incision. So that is the Western people have given us, but we must be scientific. We must change the nomenclature. And if you are doing a 3 mm, 2 mm, you call it a small incision. And we are not competing with FECO, but we are standing just opposed to the FECO and giving excellent results. So that will be our contribution to the world.
We could even call it manual skilled incision cataract surgery, sir. Very skillful cataract surgery.
Yeah,
whatever it is. Manual sufficient incision cataract surgery.
Whatever it is,
Yes.
but it is not a small incision.
Absolutely, sir. I think
find out the nomenclature, sir. We should give an award who will give the best nomenclature.
Okay, thank you so much. It has been wonderful. Huh? Thank you.
The prize for the best title. We have to find out the title. This will be competition.
Yeah.
Okay, thank you.
Thank you so much.
Before we end, there's a very, very special word of thanks to the two people actually who worked. They stayed behind the scenes, but they worked the hardest. That is Dr. Balla and Dr. Parikshit. I have to thank them for all the hard work that they have put in. It has been magnificent. It has been important that all of you luminaries, as correctly said, have been here for such a long time, have contributed so much. And I would have been heartbroken if I could not see Dr. Lobsang's video, which we at last did see. It was fantastic.
Thank you so much.
Kanagar doing such a great job. And it's a job, and in Bangalore, Dr. MS Ravindra is doing such a fantastic job. So it just speaks it all. SICS is here. SICS is here to stay. SICS is the contribution of India to the world. And we need to take SICS to that level where it would be emulated and it would be popularized in places that is the need. And it is not only the need for India, but it is a need for the world today. So, Jai Hind and Jai SICS.
Thank you. Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you so much.
Thank you. Thanks, everyone.
Thank you.
Thank you.
I have to special mention of Cipla because they sponsored this event at the last moment. They've done a wonderful job. They've been so supportive, without which this event would not have taken. So thank you very much, Cipla, for your contribution. And of course, to Sunil ji, who has stayed with us, to Sai Krishnan and to Pallavi, who have been the backbone for organizing. Thank you very much. Thank you, everybody. Have a good night.
Thank you. Good night.
Good night, everybody.
Thank you.
Thank you.